Okay. Can you see my screen?
No, not yet, Dr. Hassan.
Okay.
Not yet.
Okay, it's building up.
Hassan.
Building up. Building up.
Flinch, hello. Hello, Dr. Wafa.
Oh,
Dr.
Amr, we can
Sophia.
hear you. We can hear you. We can hear you. Can you see my slide?
Not yet.
It's starting, Doctor.
Okay.
Yes.
Can you see it like this?
Yes.
Shall I start?
Yes, please.
Okay. Okay, ladies and gentlemen, welcome to our webinar on the management of massive postpartum hemorrhage. As you know, this webinar is organized by the Egyptian Representative Committee of the Royal College of Obstetricians and Gynecologists, the International Representative Committee in Egypt. And I would like to start by welcoming you and also say that our guest of honor today is Professor Christopher B. Lynch. I want to also start by thanking our speakers today who have taken out of their time to be with us and share with us their great experience and extensive knowledge in this important field. Now, as we all know, maternal death has, this is of course Taj Mahal, and many of us have seen it, have on pictures, have visited it, but maybe many of us know that it was established by Shah Jahan for his beloved wife, Mumtaz Mahal, who died in her eighth delivery, most probably by postpartum hemorrhage. Indeed, postpartum hemorrhage is one of the important causes of maternal mortality. At least 1/4 of the mortalities are due to postpartum hemorrhage. But actually, in the past century, and more importantly, since 1990, the maternal mortality has been coming down in all over the world, but in particularly in developing countries and in African countries like Egypt and Rwanda, Ethiopia, Angola, Mozambique, Eritrea, as you can see here. And one of the reasons of that is actually our guest of honor today, Professor Christopher B. Lynch. Professor B. Lynch, like many of us, was born in Africa, in the beautiful city of Freetown in Sierra Leone. But like many of us, he traveled to the United Kingdom when I think at age 17, and he trained, or he actually qualified from St. Bartholomew's Hospital Medical School, which many of us know that it is the first medical school in London and maybe in England. After qualifying, he worked with 4 Knight bachelors. So Edward Tuckwell, who was the surgeon to Her Majesty the Queen, Professor Sir James Fraser, who was the president of the Royal College of Surgeons of Edinburgh, and Professor Alec Turnbull, of course, the Nuffield Professor of Obstetrics and Gynecology at Oxford University, and Sir Marcus Setchell, the Queen's gynecologist, again at Bath. But since 1984, he was a founding consultant in the Department of Obstetrics and Gynecology at Milton Keynes University Hospital, where he remained there until he retired in 2010. And during these years, of course, and particularly in 1997, he described to us the brace suture, the first brace suture known after his name, the B. Lynch suture. All other modifications followed the B. Lynch sutures as we know it. Following this, he became very famous. He was invited to membership of the Athenaeum Club in London. He was a runner-up for the Surgical Trainer of the Year, sponsored by Smith and Nephew Foundation. He was a visiting professor to the Cranfield University, the Faculty of Health Sciences and Translational Medicine, doing research on stem cells and ovarian cancer. He wrote many papers, published, of course, in peer-reviewed journals, and he's the editor-in-chief of the well-known international book on postpartum hemorrhage and comprehensive management, patronized by Her Royal Highness, the Princess Royal, at the Royal Society of Medicine in October of 2006. He was appointed by WHO as the Commissioner for Women's Health Improvement in Africa. He was also decorated in recognition of his work in obstetrics and gynecology and appointed an honorary doctor in the Open University. And of course, he was invited to many parts of the world to lecture and train doctors in Africa, Pakistan, Australia, New Zealand, Canada, United States of America, in India, South America, Europe, and the Middle East, where he visited us in 2011, in January of 2011, where he ran for us a beautiful course on hands-on course on postpartum hemorrhage, on the management of postpartum hemorrhage. And recently, he delivered the invitational memorial lecture to the Society of Obstetrics and Gynecology in Mysore and Pune in India. And this is, of course, the book. We all know this is the first edition, and then now there is a second edition also. More importantly, maybe for him, he was awarded the Grand Officer of the Republic of Sierra Leone, which is equivalent to British knighthood. And here, seen here actually with Her Majesty the Queen Mother. We are celebrating Professor B. Lynch, and we would love to pay him all our tribute and to thank him very much for being with us today and give us some of his wisdom at the end of these presentations, if he will do. I would also like now to thank our speakers, who I say took out of their time to be with us and share with us their experience and knowledge. Professor Amr, and I'll put them in the order of their appearance. Professor Amr Nouri, who is my predecessor. I happen to be the chair of the Egyptian Representative Committee. Professor Amr Nouri was my predecessor, and I have to say that he started all these activities we are doing today. We are all running in his footsteps. Professor Nouri is professor in Cairo of Obstetrics and Gynecology at Cairo University and also at the National Laser Institute. He's a former chair of the committee, as I say, and he's a board member also and honorary treasurer of the Egyptian Society of Obstetrics and Gynecology. And he's going to talk to us about setting the scene and the overall management of postpartum hemorrhage. And from the United Kingdom, I want to thank and welcome Dr. Sophia Webster, who is a very good friend of our committee. She contributes a lot in person and online to our activities. Dr. Sophia Webster is a labor ward lead consultant at the Royal Victoria Infirmary in Newcastle upon Tyne. She's a regular speaker at the RCO at the Royal College and international courses on operative vaginal deliveries and many other titles. And today she's going to talk to us about medical management of postpartum hemorrhage. And from Newcastle upon Tyne also, I want to thank and welcome Dr. Will White, who is a consultant in obstetrics anesthesia at the Royal Victoria Infirmary again at Newcastle upon Tyne, and who is going to help us. I was just telling him that we only know the value of anesthetists when in trouble, we terrible obstetricians. And he's going to tell us about the massive obstetric hemorrhage and the resuscitation. Thank you very much, Dr. White, and welcome. And from Scotland, I want to thank and welcome Dr. Mohammed Alam, who is a consultant obstetrician and gynecologist at the National Health Service, Lanarkshire, and he's an honorary senior clinical lecturer in Glasgow University in Scotland, the UK, and honorary consultant gynecologist also at the Shadby Maternity University Hospital in Alexandria, where I work. Dr. Alam is a graduate of Alexandria University before traveling and to England and Scotland, where he is a senior consultant there. He's going to talk to us about the surgical management and compression sutures, and also give us some tips for cesarean hysterectomy. And from Wales, Dr. Essam Hamami, who is a consultant in obstetric gynecology at Neville Hall Hospital, or at least until recently, at Gwent Healthcare National Service Trust, and Brecon Road at Abergavenny in Gwent in Wales in the United Kingdom, who is going to moderate for us today's webinar together with Dr. Wafa Benjamin, my colleague at the committee. She's the member and treasurer of our committee of the International Representative Committee of the Royal College in Egypt. She's a consultant in obstetrics and gynecology and the head of the Women's Health Unit at Matraya Hospital. She's also a member of the advisory committee of the Egyptian Fellowship in Obstetrics and Gynecology. Let me also remind you of Professor Yunus Bakri, who we would have loved him to be with us today. Bakri of Bakri's Balloon, who you all know. You may not know that he's a professor and director of oncology at West Virginia University in the United States of America. But more importantly, he qualified from our university, for Alexandria University, Faculty of Medicine, where probably he was a classmate of Dr. Ahmed Zuwail, who received the Nobel Prize in Chemistry in 1999. And for all of us, I would like to ask you to please post your questions on the question and answer section, not on the chat section, please, and mention your name and country if you would like. I know that we have at least 2,000 registrations from many parts of the world, from the four corners of the world, actually. And finally, I would like to thank Merck for their continuous support to our activity, Merck Pharmaceuticals. And with this, I leave my microphone and screen to Dr. Isam Hammami and Dr. Wafa Benjamin to carry on the webinar from this point. Thank you.
Okay, thank you very much, Professor Salam. It's a great pleasure. Can you have the screen now on Professor El-Nouri, please? It's give me great pleasure to invite Professor Amr El-Nouri to start the first lecture for tonight seminar with the setting the scene and overall management for massive postpartum hemorrhage. Professor El-Nouri doesn't need any mention, as Professor Salam said. He's been instrumental with our group for international training for the last 15 years, setting so many conferences, especially in Egypt, UK, and even in Ethiopia and the Middle East. And he's really very, very keen to train as much as we can of our generation and the younger generation to deal with this horrible catastrophe when it's happened. Professor El-Nouri, over to you.
Thank you, Professor El-Hammami, and thank you, Professor Hassan Salam, and welcome to our colleagues from the faculty, Dr. Will White and Dr. Muhammad Alam and Dr. Sophia Webster, and also our moderator, Dr. Wafa. I think we have more than 850 audience now, which is good to share the experience with all this group. We know that postpartum hemorrhage is the leading cause of maternal mortality in many countries. Sometimes it is the second, sometimes it is the first leading and cause. And 200,000 plus women die from postpartum hemorrhage each year. And it's a disaster in every aspect to the family that's supposed to be very happy in few moments and then end in death or morbidity, problem to litigation to the hospital, and also very depressing to the or health this one. And the significance of the massive obstetric hemorrhage, as all we know, the DIC that can occur, the adult respiratory distress syndrome, the acute blood transfusion reaction, electrolyte imbalance, and acute renal failure. And in many cases, we may need to go for hysterectomy. And if there are bleeding and difficulties, there's a risk to injury the ureter and the bladder. So it is really the leading cause of maternal mortality. And if you look at the definition of postpartum hemorrhage, this definition really always stops me for a while, because one of them saying blood loss for more than 500 ml following vaginal delivery, and in the same time by WHO saying blood loss more than 1,000 ml following delivery. One is 500 and this one is 1,000. So it really doesn't look really reasonable to me that really we have to stop the bleeding, whether it is vaginal delivery or cesarean section. And the primary postpartum hemorrhage occur within the first 24 hours and can be divided into minor, between 500 to 1,000, or major, more than 1,000, that can be divided again into two parts. The severe is more than 2,000 ml. But if you look at this, they did not look at the body weight. We know that there is a relation between the blood volume and the body weight. There is nearly 100 ml per kilogram. So the blood volume lost in a 50 kilogram woman is different completely from as an effect from one who is really 90 kilogram woman. And also the rapidity of the blood loss varies because it can be as severe as 150 ml per minute in cases of the atonic postpartum hemorrhage. And there is also, we should give a consideration of the anemia during pregnancy, because one who's starting with 9 gram, for example, of hemoglobin is different from one who started 13 and lost 500 or 1000 ml. So it would be better really to say that any amount of blood loss postpartum that cause hemodynamic compromise or signs or symptoms of hypovolemia should be considered as a postpartum hemorrhage. And this slide, actually, I took it from Chris Lewis, that saying that the placenta removal leaves a 20 ml diameter wound that continues to bleed if the uterine musculature does not contract. So you can lose really a lot of blood. We are saying that a woman can die from postpartum hemorrhage in 2 hours, and from an accidental injury, it can be 24 hours. So it is really the most actually rapid killer in bleeding. And it's very important to look at the early, maybe I can have to get, sorry. Early recognition, identification of postpartum hemorrhage, and I'm sure this will be actually repeated several times. We have the atony, we have retained tissues, we have coagulopathy, and we have the trauma. So one really should recognize who is at risk of this. We know that multiple pregnancy, fetal macrosomia, any increase in the stretch of a muscle will weaken the muscle or prevent it from a good contraction. So this is a risk for tone. The tired uterus as a result of failure to progress in the second stage or prolonged third stage of labor, this can also lead to problem with the tone. The retained placenta and accreta, and we have the preeclampsia and abruption, you look for thrombin, and of course, if there is cesarean section, perineal laceration, episiotomy, this can increase the trauma. So one should be aware of the risk prenatal of this woman. The timing of delivery is really very important. If you have a placenta accreta, you shouldn't wait longer than 36 weeks by any means. Placenta previa, again, 37 weeks. If you have a prior classical cesarean section between 37 to 38, prior myomectomy, you can, depending really on the type of the myoma and the size, but extensive myomectomy, you should think about 36 to 37 to avoid the rupture of the uterus or the severe bleeding that can occur under difficult circumstances. The visual estimation of the blood loss is very important. So we can say that this patient bled 500 ml or 1000 or 2000, but be assured that visual estimation of blood loss is inaccurate, underestimated in up to 50% of the cases. And again, each hospital really should have an accurate methodology to estimate the blood loss. For example, this one, they use an under buttock drapes in normal vaginal delivery. Others, they use the suction for the cesarean section, but they have actually to start calculating after the release of the amniotic fluid. So to avoid, the other overestimation or underestimation, or weighing scales where you measure the swabs or the towels before and after, and remember that each gram corresponds to 1 ml. So this, in addition to the early identification, I'm not going to talk this, I'm sure this would be repeated also several times, but it's really very important. If we have up to 1000 ml, the blood pressure may remain stable, but the patient maybe have a little bit of palpitation and dizziness and tachycardia. So the red blood cells, they make several rounds quickly to increase the pulse rate to deliver more oxygen. And if the blood loss is more than 1500 ml, you start to have some fall in the systolic blood pressure. And then the patient start to feel weak. Again, you need more oxygen, so the lung works more. So in addition to the tachycardia, you will have tachypnea, and you can get all postural hypotension. More than this, the patient will become restless, less blood going to the brain, and to the kidneys start to shut down, so you get oliguria. And then after that, if you have really more than half of the total blood volume, you have a marked loss or decrease in the systolic blood pressure, you start to have collapse tachycardia, the pallor, the cyanosis, the confusion. And so this is what we say, that we do not only rely on the postpartum hemorrhage as a visual or as an estimate, but also on the symptoms and signs of hypovolemia. This is a modified early obstetric chart, and this is from the sign that we can apply the previous slide on this. We look at the respiratory rate, the oxygen saturation, the temperature, the pulse, the blood pressure, and then you have this in white, so it's fine if it is in this actually level. If it goes to yellow, then it is it's warning. If you have 2 yellow, then you have to report. If it is red, then you have to report this and you start to act. This also slide is about the rule of 30 and the shock index. If you have blood loss more than 30% and or pulse rate increased by 30 beats per minute, or respiratory rate more than 30 per minute, or systolic blood pressure decreased by 30 millimeter mercury, or urine output less than 30, or hematocrit dropped by 30. So this is what we call the rule of 30 and the shock index. The management is very important, that there are several things you have to do at the same time. You communicate, you resuscitate, you monitor and investigate, and you try to stop the bleeding. And the communication is the first thing, really. You have to alert all the key stuff. You have the obstetrician specialists, the midwives or the nurse, the theater nurses, the blood bank, the anesthetist, very important, and the hematologist as well, and the porters who are going to get you the blood or the blood products. And maybe you can have a postpartum hemorrhage emergency box, so someone can get it to you immediately. So the station we know the ABC, and then we have another C, which is the compression. The airway, the breathing, the circulation, and then the compression. And we know that compression is very important in any emergency or any bleeding. You need to give oxygen, head down, and you need to increase the inspired oxygen to increase the perfusion of the tissues and help delivery more oxygen because of the loss of blood. So you need to compensate of this. You need to put 2 wide bore cannula, we say around 14 to 16 gauge. And this is, you aspirate at the same time, withdraw 20 ml of blood, and you send it for the diagnostic test, usually full blood count, coagulation screen, electrolytes, and you do cross-matching at least 4 minutes. And really, this is very important slide. If you look at the gauge here of the cannula, we have the 14 and we have the 20 and 24. And if you look, all of them are color coded depending on the country. And here, if you find that, you look at the flow per ml per minute. If, for example, if you put a 20 gauge cannula, you have 54 ml per minute. So you really need around 20 minutes to get 1 liter, for this. But if you have the 14 gauge, the wide bore cannula, it's nearly 250 or 240. So you can get the 500 ml in 2 minutes only. And if you have 2 wide bore cannula, you can get 500 ml in 1 minute, which is very important to put this cannula. Right, and this is the PPH emergency box that should be actually looked at and make sure that the everything is ready in this one, including the even the laminated paper of the management of the postpartum hemorrhage. And these are the things. You have 2 cannula for wide bore, you have the fluid to syringe to withdraw the blood, and you have also the special tubes for every blood test you want to take. And then you have 2 at least 2 liters of each of the crystalloid and the colloid. And of course you have the intravenous drip, for that. You can have the swabs. You can have also the laminated management. So anyone really can start this. These are the compression non-pneumatic anti-shock garment, which can be used especially if you are in a place and you need to transfer the patient, you don't have the facility. So you can actually wrap this around the leg. You have to go in this order, 1, 2, and then 3, and then 4. And here there is like a ball sponge where it causes compression over the uterus. And all this really will reduce the blood in this area, but it will shift the blood going to the important structure to the brain till you transfer the patient. And remember that the aortic compression also sometimes can help in some of the patients. So you need to restore the circulation first. The crystalloid, you give maximum 2 liters, not more than that. The colloid, you give 1.5, and you start first by the crystalloid and then by the colloid after that. And your idea really, or your aim, is to improve the oxygen carrying capacity. And this can be done by either packed group specific red blood cells or O negative blood. And so this is very important because 98% of the oxygen will be carried by the hemoglobin, only 2% in plasma. So you need the blood. And remember, it has to be warm and rapid, and there is no filter. So this is very important. I just want to remind you of the oxygen dissociation curve, where they put the saturation of the oxyhemoglobin against the oxygen tension. And if you decrease the temperature, there is a shift to the left. And if you increase the temperature, there is a shift to the right. So if it goes actually to the left, this means that it will retain more oxygen, so it will not give the oxygen to the tissue. So you have to warm the fluids and the blood before giving this one. The other thing, that if you infuse blood or any fluids cold very rapidly, you can actually cause affection of the SNA node, and it can lead to cardiac arrest from the blood transfusion rather. So you have really to invest in a blood warmer, and a blood warmer should be present in any hospital that is doing or treating patient, especially at risk of postpartum hemorrhage. These are different types of blood warmer. And very important to have with a blood bank what we call the massive transfusion protocol. Each blood bank should have at any time a minimum of 4 units of ORH negative packed red blood cells. And also they should have the ability to obtain 6 units of packed red blood cells and 4 units of fresh frozen plasma for a bleeding patient. And again, there must be an emergency protocol understood by the blood bank and the ordering party, who is going to order and what forms, and who is going to bring the blood to the labor ward, for example. So what's the mechanism? And also they should have a mechanism to obtain the platelets and additional products in a timely fashion. The second thing really in the management is to monitor and investigate, as from the modified obstetric chart, you have the respiratory rate, the heart rate, the blood pressure, saturation, Foley's catheter, early warning chart. So all this really has to be done, and we have to do the repeated the hemoglobin, the hematocrites, the platelets, and the clotting screen. We have the prothrombin time, activate partial thromboplastin time, fibrinogen. And in the meantime, while we are investigating, we have to investigate also the cause of bleeding, whether it is a tone, a tissue, a trauma, or thrombin, and consider the ICU, the intensive care unit, especially when the bleeding is controlled. You can have in the like the blood sugar portable one, you can have one for the hemoglobin, and you can do this. Okay. The main therapeutic level is to keep the hemoglobin more than 8 grams, the platelets more than 75,000, the prothrombin less than 1.5 by the mean control, activated prothrombin also less than 1.5, and fibrinogen should be more than 1 gram per liter. So these are the main things. Just sharing with you what a few of the things that we can do to reduce the bleeding during the cesarean section. And so maybe we can change the definition of postpartum hemorrhage. So first, those at risk should deliver in hospital with blood facilities. We do active management of the third stage. And we can actually secure the bleeding points before delivery of the placenta, after delivery of the baby, and before separation of the placenta. There are bleeding from the lower edge or lower lip of the lower uterine segment incision, and sometimes from the angle, especially if there are extension. So you have to secure this hemostasis with either green Haemorrhage clamps or with your fingers till you aspirate the blood, and then put the green Haemorrhage clamp to secure the bleeding. So you can reduce a lot of blood loss while waiting to deliver the placenta. You have to check, because sometimes after we close the uterus, we don't see the bleeding coming from the vagina till really the blood start to dribble over the foot of the, or the feet of the assistant. So you have to check that the uterus is contracted, and massaging the uterus every now and again to be sure it's not a tonic. And again, using the early identification modified obstetric chart. So to stop the bleeding, we can use a combination of pharmacological, medical, that I'm sure Dr. Sophia Webster will talk about it, mechanical, and surgical method that Dr. Muhammad Alam, my dear friend, will talk about it as well. So these are the friend, remember the bimanual compression, and these are the medication I'm sure Dr. Sophia will cover, so I'm not going to decree this, but you have to go in the right order of this one. The balloon tamponade, it can actually be a definitive treatment of postpartum hemorrhage, especially in the atonic. And as Dr. Salam talked about Yunus Bakri, he actually invented the Bakri balloon, where they inserted into the uterus, and you fill it between 350 ml to 500 ml. You don't have to fill it, all of it, and it reduces the blood really significantly, and you can avoid going to theater once this happens. But there are other, it's not available everywhere. It's quite expensive. They are now doing a modified one for this one modification, or second generation Bakri. But there are others like the Rush balloon. There's a single stacken balloon. They use it for the esophageal varices. There's this one, they call it every moment, which they are making a balloon that's really very cheap. And they have this, if you look at, if you look here, this is actually the pack of it. Here there are two elastic strings. They put either the condom or the supplied balloon, and they put it on the top, and it will seal it, and then you can use it immediately to this one. There are the EBB balloon that they have also a drainage part in the middle, and they have a part inside the vagina, and part is inflated, one inside the uterine cavity and the other one in the vagina. The most important thing is really that you keep filling this while your two fingers inside the vagina at the level of the cervix, like really doing an artificial rupture of the membrane. And you feel the balloon. If it starts to bulge through the cervix, then you stop filling. And you can say, you can tell how many syringe you filled, so you can record that this is 350 ml to 500. Usually it is 350 to 500 ml, not more than that. This one, actually, we use a Nelton catheter, and we put it inside the glove, and we put Vicryl or silk suture here, and we make it tight, 3 or 4, 5 knots here, and 3 and 4, 5 knots, and you cut the rest of the fingers of the glove, and you can put another one beside it to drain outside. You can do it in any hospital. We use the 22 or the 24 gauge Nelton catheter, and then you can close it here by either a clamp or like a Kocher clamp or an artery clamp after you fill it with the fluid. Sometimes you need to fill the vagina with a swab or pack to make sure that it will not be dislodged, the balloon tamponade. Again, it is a definitive in 85%. Once you take the decision, you can notify the theater that you may come to them, you put the balloon tamponade, and then you can go to theater. The beauty of some of these one, that they are rigid, so you can apply it like applying, like doing a rupture of membrane. So you put your fingers inside the cervix and you just guide this, because they are rigid, they can go, you don't have to grab or grasp the lip of the cervix as happened with the softer types of the balloon. Then you go for the surgery, and I leave also this to Professor Muhammad Allam. There are different, starting from uterine artery ligation to step-wise technique of where you go in a stepwise fashion. Professor Salah Abdurabbu actually read this step
It seems that there is a connection problem, Dr. Amr. He may lost connection for a while and he will come back. Just give him a few minutes, please.
Can I take this opportunity and say that apparently Dr. Bakri is with us, Dr. Yunus Bakri of Bakri Balloon. And if this is the case, I would ask him to, I would try to ask him to join us. We tried to contact him, but unfortunately we could not get hold of his emails. Dr. Amr Nouri, you're back.
I don't know what happened. So
all right,
shall I continue, or I'm fine if I nearly finished. Really, I'm not going to talk a lot. But again, remember, I'm sure you have the hemostatic brace suture, but this Professor Alam will talk about it. Documentation is really very important. The timing of attendance and the timing of arrival, the sequence of events, the administration of the pharmacological agents, and the timing, all these patients who decline blood products, sometimes like Juhafa witness, or for any other reason, we have to know that the progression from observation and fluid replacement to mechanical hemostasis, like the balloon tamponade, to hysterectomy must occur faster in these patients. We consider the cell saver in these cases to use the autologous swashed blood, and consider involving a second consultant. And if you want to go to the theater for suspicion of internal bleeding, you have to do it very quick. The fire drills are very important, and the post-hemorrhage management to debrief with the whole obstetric care team, and also debrief with the patient and the family, and document is very important. These are the tools the hospitals can use to implement the directives: visual aids, checklists, algorithm, risk assessment table, medication dosing tables, and debriefing forms. This actually the form of the postpartum hemorrhage, and this we did this actually poster, and it was taken into the textbook of postpartum hemorrhage, and that's been edited by Professor Arul and Chris Lewis. In my final slide, really, I would say that recognition and prevention for every patient, including risk assessment and universal active management of third stage of labor, readiness of every unit of a blood bank and massive transfusion protocol, medication kit and postpartum hemorrhage box, hemorrhage team education and drills for all stakeholders, the response with the checklist and support for the family, the patients, and also for the staff for all significant hemorrhage, and the reporting and the multidisciplinary review of these cases. This is the video, the picture we took in 2011. If you can see here the date, 27th of January 2011. This was in Alexandria in the Women Health Center, which is overfacing exactly the mosque that the revolution in Egypt in Alexandria started in the same day we were there. So we managed to go back to Cairo. Here is Chris Lewis, professor, is our late professor Chris Lewis, Prof. B. Lynch, Professor Salam, Professor Gamal Surur, who was the ex-chair of the representative committee and the chair of the FIGO. And here is Professor Arul Kumaran, the professor also Royal College chair, president, and FIGO president. And this is our ex-chair, Professor Amr Shalani, Professor Hassam Al-Hammami here, and this is Mahantish as well from UK, and Dr. Shokri, our dear friend, and Madame Azza Al-Tobgi. This is actually the book that Professor Salam, I would like to draw your attention to this. If you take this to the address, the website, you can find this book in chapters, which you can open it chapter by chapter, or if you would like to buy the book, you can buy it, but you can find. Thank you very much for your attention, and I'm ready for the 2 to 3 questions, and back to Professor El-Hammami and Dr. Wafa.
Thank you very much, Professor Nouri, for this very comprehensive presentation about the overall management of PBH. As Professor Salam mentioned, we got Professor Yunus Bakri with us, and he's asking the opinion of the panel on the management of placenta previa percreta with bladder wall invasion. What is the experience in Egypt in previa percreta bladder wall invasion? And he also thanked Professor Salam for his introduction.
Well, actually, in Egypt now we have a high incidence of cesarean section, maybe the 3rd country of cesarean section rate all over the world after, I think, Brazil and Dominican Republic. So we have a lot of cases of placenta accreta, and some of the hospitals like Asr Al-Aini, they have a placenta accreta team diagnosis and management. Either you go for hysterectomy if the patient is having many children and has completed her family, but sometimes the patient really here in Egypt, they do not want to lose the uterus for either social or other reasons, or they would like to get another child or another sex of child. There are different types of conservative management for this. And I think the most important is to choose the time of the placenta of the delivery, and it should be between 35 to 36 weeks before further stretch of the lower uterine segment occur and before starting to bleed, because many of these patients will go into labor and will start to bleed before. And a very important part is to do very good dissection of the bladder in a hemostatic way and once you have this, really you can do you can do different types of compression sutures after you deliver the placenta. Either you manage to deliver it or you do resection and then resuturing of the uterus and put the compression sutures. So this is the part. Sometimes also you can use the Bakri balloon or a similar tamponade once you finish this procedure. Thank you, Professor Hassan.
Second question, Amr, is from Sister Sumaya in Qatar. She asking, can we insert Bakri balloon in the labor suite, or do we have to do it in theater?
Well, if you can examine the patient in the labor suite, I think you can do it in the, because every second really matters. So if you have this rigid balloon, whatever it is, a Bakri or other made in the theater from either gloves or from the condom and Nilton catheters, because some of the hospitals, they do not have the Bakri balloon, for example, or other balloons. So if you can do the vaginal examination and go to the cervix, then you can actually apply it very easily, like exactly when you are doing rupture of the membrane using an amni hook. Exactly, this is the same. You do it and you feed it inside. You can save a lot of time if you can do it in the this one. But if the cervix is closed or become very tight, then in this case you have to go in the theater.
Okay, thank you very much. I have a lot of other questions. We should keep it at the end of the presentation. So I pass it on now to Dr. Wafa Benjamin.
Thank you, Dr. Assam. Thank you so much, Professor Nouri, for shedding the shadow on very important issues about the management of postpartum hemorrhage, and mainly the concept or the explanation of why we are doing every step in the management. Thank you so much. Now I'm really delighted to present our next speaker, Dr. Sophia Webster. Dr. Sophia, actually, we consider here as one of the Egyptian Representative Committee members. She participated in many activities with us in Egypt, and we are really happy to have here today. She's going to talk about the medical management of postpartum hemorrhage. Dr. Sophia, please.
Well, thank you for the kind invitation, and it's really a pleasure to be part of the webinar. I'd really impress on everyone that it's good to hear the theory and be involved in the discussion tonight, but it's also very important to take part in the practical sessions that I know will be coming later on as well, because it's a very practical topic. So Dr. White and I are from Newcastle. We work here in this hospital, the Royal Victoria Infirmary. It's attached to Newcastle University. We have a lot of high-risk women and high-risk pregnancies, and we deliver about 7,000 babies or women every year. Of course, there are multiple pregnancies as well. So we're here to share our experiences. I'm going to talk about medical management, and Dr. White will come on to talk about resuscitation and massive obstetric hemorrhage. So I just wanted to really demonstrate, first of all, that, postpartum hemorrhage is something that's common to all of us working on the labor ward. Perhaps you've got a woman who's in her first labor, you've undertaken a vacuum-assisted delivery after a long labor, and she's received the 3rd stage active management with oxytocin. But as the placenta separates and you're starting to think about suturing her perineum, you really get brisk bleeding that's, really very fast. And you're thinking, how do I manage this now? Or perhaps, you're in theatre delivering a woman electively and you're doing a cesarean section because she's got a multiple pregnancy, but she's got a comorbidity of preeclampsia. And although the delivery of the twins is uncomplicated, after delivery, the uterus doesn't contract well, and really you're getting very fast bleeding from the placental bed. So then you have to think, how do I manage this case of postpartum hemorrhage here? And of course, more commonly in Egypt is morbid adherence of the placenta, and in our environment we perhaps get one patient every 2 or 3 months, and usually we know that they've got a problem with their placenta. But as I understand it, in Egypt and in Cairo, then often these women will be undiagnosed. Perhaps they present with an antepartum hemorrhage and you take them for an emergency cesarean, and you're dealing with a lot of bleeding. So I think that's the first thing to say, really, that you've heard that postpartum hemorrhage is important because there's associated mortality and morbidity of women, but it's also something we're dealing with every day, and there are resource implications. And the other thing, just to remember is that it also very much affects the patient's experience of their birth. So I see quite a number of women in my antenatal clinic who come after their first delivery, and perhaps they had a long labor and a forceps delivery and a postpartum hemorrhage, and they may or may not have received extra medications and gone to theatre and received blood transfusion, but most of them have some trauma associated with the emergency situation they found themselves in, and they feel very out of control. And I think that in the UK, patients' experience is becoming very, very topical. And often in the next pregnancy, they're thinking, how can I avoid this? And they ask for perhaps a planned cesarean. So, I think the important thing to realize is that really, the fact that there's a postpartum hemorrhage can be very far reaching. So in Newcastle, which is where I'm working, we realized that we were out of keeping in terms of our rate of postpartum hemorrhage greater than 1.5 litres, which is a reportable morbidity. We realized that actually our rate was 3 to 4% of all deliveries, sometimes even 5% some months. And if we compared that to our colleagues within the whole of our region, the north of England and nationally, we were an outlier. Now, the thing to bear in mind here is that as you heard from Professor El-Nouri, we very often underestimate blood loss. And so as an aside, we had an activity on our labour ward where I took some expired blood from the blood transfusion lab, and we started putting some blood on towels, on sanitary pads, on the birthing stool, down the toilet, as you can see. And we had like a competition among our staff to see who could get closest to the actual volume of blood. And the really interesting thing was that people were very far out with their estimates. And the other was that the administration staff, so not clinical staff, but administration staff who came just for interest, were the ones that got closest to the number. So it really demonstrated to us that we're very poor at estimating blood loss. Now, you've heard that hemorrhage causes deaths. Thankfully, in the UK, which is very different to Africa and sub-Saharan Africa, we don't have a huge number of women that die, but of course every death is significant. More of a problem in the UK is morbidity. But just to give you a flavor of one of the women that died in the UK that was actually described in our last Saving Lives, Improving Mothers' Care maternal mortality report, here's her story. So an anemic woman had a cesarean section after very prolonged labor. She was of small stature and lost almost 1 litre at surgery. No blood was ordered. 3 hours later, when she then had bled 2.5 litres vaginally from what was thought to be an atonic uterus, she was initially resuscitated with fluid, and she received 8 litres of crystalloid and 2 litres of colloid, and that was before the blood became available. She subsequently developed pulmonary edema, was intubated, ventilated, transferred to the intensive care unit, and she died from ARDS, acute respiratory distress syndrome, sepsis, and multi-organ failure a month later. So, these are the tragic stories we're dealing with. And I think we can talk about numbers and statistics, but I think by describing what actually happened to a particular woman really can, impress the importance and the story on you. So when we talk about morbidity, which is more common in our scenario, we also have to think about resource. And when we talk about resource with regards to postpartum hemorrhage, you're talking about perhaps staffing and theatre time, but you're also talking about blood transfusion. And blood transfusion is often seen to be the thing that is going to save a woman that's bleeding. But we have to remember that, yes, although we need to give blood in order to avoid maternal morbidity and mortality, and avoid, women, really running into trouble. We need to balance that against the kind of costs associated with blood transfusion, and costs are financial. But availability of blood, particular certain types of blood, isn't always easy, and there is a theoretical potential for infection, antibody formation, which may cause people later in life, if they need an organ donation, for example, cause them to have difficulties, or if they need future blood transfusion. And of course, there are acute problems with blood in terms of transfusion reactions. So, blood transfusion does cost us something in terms of how we run our service. Now, bleeding can be fast. You've heard about some physiology already from Professor El-Nouri, but just to highlight again that if we look here on the y-axis cardiac output in litres per minute against weeks of gestation, you can see that a woman who's in late or the late first stage or the second stage of labour has somewhere between 7 and 9 litres per minute of cardiac output. So once she starts to bleed from her 20 centimetre placental wound that was described in the previous presentation, you can imagine that she can very quickly be losing blood. And of course, that bleeding can be of large volume as well. We know that pregnant women, they do increase their blood volume and their plasma volume as well as red cell volume throughout pregnancy until the point of delivery. And we know that they compensate as well to some extent, but still, you know, the volumes that they can lose, as Dr. White is going to describe later, can be very large. Most healthy mothers will tolerate a 500 ml blood loss. And perhaps an average 70 kilogram woman will have a blood volume of about 7 liters or 7,000 milliliters. So if we think about a 40% total blood volume as being regarded as life-threatening, then we're talking about, for a life-threatening bleed, something in the region of 2.5 to 3 liters. And the aim of our management in terms of prophylaxis against PPH and treatment of PPH is to prevent the hemorrhage escalating in order to prevent morbidity and mortality. Now, one very important point that is just worth mentioning is something that the ERC-RCOG, the Royal College of Obstetricians and Gynaecologists, in their postpartum hemorrhage guideline really highlight, is that really you want a woman to be going into the delivery scenario, whether that's labor or planned delivery, with any antenatal anemia treated. I mean, it's the basis of that means that in the UK, you screen women for anemia in pregnancy. So they would be having a full blood count done at the time of first contact, which would hopefully be sometime at the end of the first trimester. And we use then a hemoglobin level of 110 grams per liter as the lower limit of normal. And then we screen them again at 28 weeks of gestation, where we use a level of 105 grams per liter. And if a woman would be found to be anemic, then that would be investigated. And of course, often, and perhaps usually, that would be iron deficiency, which you can look at by running a ferritin test. If iron supplementation was indicated, then that should be given. And of course, that can be given orally, but there are also parenteral options, so intravenous options, for example, Ferinject or Monifer, to treat anemia as well. And we know that if we treat anemia, then we would expect that the morbidity associated with postpartum hemorrhage would be less. So the name we gave to our project in Newcastle was Robin, and I'm very grateful to a colleague, Dr. Danny Morland, who's a colleague of Dr. White and I, who's given me his slides here. And we always thought it's nice to give a project a really snappy title so that people can remember it and talk about it. And we came up with Robin, which was Reducing Obstetric Bleeding in Newcastle. And it really was a multidisciplinary initiative to reduce the rates of postpartum hemorrhage, because as I said earlier, we were an outlier. I say were because actually we've improved now based on the project, and we were an outlier in terms of the rate of women that experienced a blood loss of greater than 1.5 liters. So this was a slide we showed to our staff when we were launching the project. You know, we said to them, do you realize that half of our women that deliver in our hospital lose over 500 mils of blood, and 5% of them most months lose over 1.5 liters, which the ERC-RCOG, the Royal College, are classifying as a major PPH. And do you know that 1 in 100 of our women will lose over 2.5 liters of blood? And that's what we're calling a massive obstetric hemorrhage. So we're really trying to get people on board with what we were trying to do by impressing on them the importance of the problem. And we drew this diagram. We said, you know, we looked at the year 2017 to 18, and we had almost 300 women that required a blood transfusion in our service. And that was a risk of 1 in 20 of women that stepped through our door to give birth, which, you know, I think is quite a alarming figure in many respects. We were asking people, why did they think we were an outlier for blood loss? And it was decided that it was multifactorial, but if something was multifactorial, we needed a multi-pronged improvement strategy. And that would, of course, involve the multidisciplinary team. You know, our aim was to reduce postpartum hemorrhage rates to less than 4% of all deliveries. And we decided that this was the way to do it. We were going to recruit a multidisciplinary team. We're going to define the problem, risk assess the patients, adapt and create pathways that would improve patient care, and that would involve some paperwork. And of course, as you've heard from Professor El-Nouri, very important for postpartum hemorrhage management is an obstetric major hemorrhage protocol. But we also thought that, you know, branding and publicizing was going to help drive the project. So our team, just so you know, because it's very important to be multidisciplinary about postpartum hemorrhage, not only involved obstetricians, but it also involved anaesthetists. In fact, it was driven by the anaesthetists, but also midwives who are really very involved on our labour wards. And we always have one midwife looking after one woman in labour, and they work very closely with the rest of the team. But we also involved our haematology colleagues and our transfusion specialists, as well as our risk management team, who would be the ones that would always be reviewing these cases where there were major bleeds, to see if any lessons could be learned. And of course, our colleagues in the information technology department. So the first thing we thought was that we needed to improve estimations of blood. So you heard from Professor Al-Nouri that estimating the volume of blood loss is incredibly important. And then you heard from me earlier in this talk that actually most people estimate blood loss poorly. And we've all been the one in theatre who kind of, thinks, oh, probably the patient's lost about 800 mils. It kind of feels like that. There is evidence, as you see here, from this paper in 2004 from America, that if you teach people about blood loss and you perhaps give them some swabs and ask them to hold them and weigh them, and perhaps you play some games like we did on our labour ward with estimating blood loss in different scenarios, then you can improve the way that they estimate bleeding. But we would have to say that the gold standard is not actually EBL or estimated blood loss. It has to be MBL, measured blood loss, or what the Americans say, QBL, quantified blood loss. And you saw that Professor Al-Nouri had given some examples of some drapes where blood can be collected. The other described techniques are that you use weighing scales, and you would know all of the dry weights of your standard products, like your sanitary pads and your towels and your gauze swabs, so that when you put the blood-soaked equivalent on the weighing scales, you can take off the dry weight and then calculate the weight of the blood on there. So you need really a laminated list of all the commonly used items, and of course then you would add that. You'd use the volume of blood that you suck at the time of the cesarean section, or otherwise, and you would add those volumes together. So this is what we did on our delivery suite. You can see that these were the weighing scales we had on wheels so that we could move them up and down the delivery suite easily. And then we had this laminated card, and here you've got gauze swabs and pads and towels, etc. And the dry weights are here. And then, at every delivery, whether it was a vaginal delivery or a cesarean section, we always had a midwifery support worker who was assisting the team, who would weigh the various items and then give us a measured blood loss. So the next part is to do a risk assessment. And again, this has already been alluded to, and that the 4 T's are the causes of postpartum hemorrhage: tone, trauma, tissue, and thrombin. But we then can dig deeper within those 4 T's, and some of these risk factors that we can find are actually known antenatally. So perhaps the patient has had a previous postpartum hemorrhage, certain ethnicities, Asian ethnicity rather than the white ethnicity, would be more likely to have a heavier blood loss, obese women or anemic women. And then there are certain risk factors that would develop intrapartum. So here are the examples. So delivery by emergency cesarean section would increase your risk by 4 times, delivery by elective cesarean 2 times, induction of labor, retained placenta, episiotomy, and then operative vaginal delivery, prolonged labor, big babies, pyrexias in labor, and nulliparous women over 40, interestingly. So, you can start to see that already you can pick out the patients that might be more likely to bleed. So that's here, risk assessment. And then we looked at what was already out there, and from Health Improvement Scotland, they'd put together certain pathways, for women when they were coming into the labour ward. So they started with a risk assessment. So every woman that arrived on the labour ward had this risk assessment. So you can see here that the midwife will go through this with the woman and tick if any of these antenatal risks were appropriate or applicable. And then if any developed during the labour, they would also be ticked. And this paperwork then reminded the midwife at the time of delivery that all blood loss to be honest, before delivery and immediately after, trying to exclude the liquor, of course, all of that would be measured. And then if a woman was at increased risk of postpartum hemorrhage because any of the risk factors were flagged, then she would be treated early. So by treating early, we're talking about, making sure intravenous access is present, and thinking about cell salvage if we're in cesarean section, but also making sure that the management of the third stage was appropriate and what we call active. So let's talk about active management of the third stage. For that, we can go to the ERC-RCOG guideline on the prevention and management of postpartum hemorrhage, which was last updated in 2016. And the ERC-RCOG would say that your standard active management of the third stage at vaginal delivery, where there are no identified risk factors for postpartum hemorrhage, we should be giving oxytocin 10 international units as an intramuscular injection. Now, if there are identified risk factors for postpartum hemorrhage, the ERC-RCOG would say that you should check if the patient's got preeclampsia or hypertension, because that would be a contraindication to giving symptometrin, which is ergometrin with oxytocin, because that's an equivalent and in fact a better drug to prevent postpartum hemorrhage between 500 and 1,000 mils. And in fact, as part of our project, we switched from giving oxytocin as a standard to all of our women to giving symptometrin to those where there was no contraindication. Now, within that, of course, there is some acceptance that there will be side effects for some women of giving that drug, most commonly nausea and vomiting. And then the ERC-RCOG would say that at cesarean section, oxytocin 5 units should be given slowly intravenously. And this is a new addition, that if a woman is thought to be at risk of postpartum hemorrhage, perhaps there are additional risk factors that have been identified, it should be considered that she should also have tranexamic acid, which, as you'll know, is an antifibrinolytic. And the dose there is usually 1 gram, which is also given intravenously. Now, you might ask about carbetocin, and that was mentioned by Professor El-Nouri, and that is licensed in the UK for prevention of postpartum hemorrhage at cesarean section. But there's been a national decision that because when the trials have been looked at, including Cochrane reviews, that there's no significant difference between carbetocin and oxytocin in terms of the reduction of PPH. It's not being rolled out and commonly used, although I do think that's different in other countries. And in Canada, for example, I think they're using carbetocin at cesarean section more. So measured blood loss, we've got that. So just a reminder, we need to weigh everything, measure everything, and record blood loss accurately. So then, so after you've done your risk assessment and you've made sure that patients had active management of the third stage, these were the further pathways that we developed. We tried to keep it simple. So you can see here, when the patient would reach a measured blood loss of 1 liter, all of these things need to be considered. So first of all, communicate, like you heard from Professor El-Nouri. So who needs to know that that situation is happening? Usually for us, that will be the coordinating midwife on the labor ward, the senior training doctor, the senior registrar, the senior anesthetic training doctor, and one of the midwifery assistants. And then people need to be thinking about the cause of the postpartum hemorrhage. Is it uterine atony? Has it been a multiple pregnancy delivery or a patient with a large baby, or is there significant perineal trauma, or is there retained placenta? So already you need to be thinking about the cause, and then the appropriate actions need to kick into place, like emptying the bladder, making sure access is present intravenously, thinking about blood tests that should be ordered, and whether or not blood should be ordered from the laboratory, the giving of fluids. And I'm going to leave this resuscitation part to Dr. White to explain more. And then, moving on to thinking about giving uterotonic, so medications to aid uterine contraction, as well as, checking the placenta that, it's intact and you're not supposing that there's any retained placental tissue left, and inspection of the genital tract, etc. And you can see that tranexamic acid is here, because as well as a prophylaxis for PPH, tranexamic acid is also being used early now as a treatment when a woman is bleeding, and certainly when she's reached 1,000 mils. So then we said, well, if you're now at a point where you've measured the blood loss that's happened and you're approaching or you're at 1.5 liters, really at that stage, because you're trying to anticipate what might be necessary moving forward, which may of course include evacuation of any retained tissue or the introduction of a Bakri intrauterine balloon, etc., then you should be already moving at that stage the patient to theatre in order to save time and be time efficient and therefore reduce blood loss. So you see the same boxes here. It's about communication, informing. So at this stage, we're making sure that, already we're making sure that the senior people are aware. So not only the registrar, obstetrician and anesthetic doctor, but now the consultants, this, the transfer to theatre and the time arrived, and then actions, which also now include, coagulation studies, blood gas analysis. You see here repeating the tranexamic acid, because actually the treatment dose is 1 gram, but you can give a 2nd gram 30 minutes later, and reviewing the uterotonic medications, which are all listed over this side. Once we reach 2000 mils, then you need to be thinking about additional inputs from the hematologist and the blood transfusion lab, etc., really making sure that the senior obstetrician and anaesthetist are involved. And over here is a summary of the treatment. And, for the rest of this talk, I'm going to focus on the medications, because my colleague is going to talk about surgical management. And you can see the record of the uterotonic medications would be recorded here. So the medications we're using are oxytocin, ergometrin, or symptometrin, an oxytocin infusion, and misoprostol and carbaprost, which I'm going to go on to talk about. So in terms of our Robin project in Newcastle, then, we were really pushing the measuring of blood loss. We changed to symptometrin for all vaginal deliveries, and we used our paperwork, evaluated our paperwork and our pathways, and we have managed to demonstrate a sustained decrease in the rate of PPH as we hoped, which is, a real win. So we're very excited about that. So let's come on to talk about stopping the bleeding. The 4 T's we know about: tone being and uterine atony being responsible for 70% of all postpartum hemorrhages. The RCOG say that in order to stop or arrest bleeding, clinicians should be prepared to use a combination of not only pharmacological, so medical methods, but also mechanical and surgical methods to stop postpartum hemorrhage. And those methods need to be directed towards the causative factor. So you saw in the previous slides that communication is happening between professionals. At the same time, people are thinking about what is the cause, and then actions should be related to the causative factor. Now, of course, there may be more than one. The patient may have uterine atony and trauma, perineal injury, but you really need to be thinking at an early stage, what is the cause here, and directing your actions and your treatment appropriately. Where uterine atony is perceived to be a cause for the bleeding, then there should be a sequence of mechanical and pharmacal measures which should be instituted internal until the bleeding stops. And you can see that here. This is from the RCOG guideline. And just to focus in, so you've got your communication, calling for help, making sure that the correct people are involved. Then you've got your resuscitation, which Dr. White is going to talk about, alongside monitoring and investigations. But here is your medical treatment. So, talking about rubbing up the fundus of the uterus, bimanual compression, and making sure the bladder's empty, and then, using all of the different medications that you should have on the labor ward in order to try and arrest the bleeding. And moving on down here to moving to theatre, surgical measures and balloon tamponade, etc. And, I think balloon tamponade is a very interesting topic. And the question is, of course, which balloon have you got available to you on the labor ward? And we're very lucky in Newcastle that we're usually using the Bakri balloon, which is very easy to get hold of and easy to use and very effective. But, the question is not just, can you use it and have you got one? It's kind of where in your management process you would use it. Because I think, certainly 10 years ago, there was this idea that you should give your your oxytocin and your oxytocin infusion and your ergometrin, and then you give your doses of carbaprost every 15 minutes. And only then, when you started to get to 45 minutes or an hour, was balloon tamponade considered. But really, balloon tamponade has come, I think, further up into the management protocols. And certainly, personally, if I've got a patient that's bleeding and I've already given a bolus of syntocinon, and I've given syntocinon infusion, and I've given a dose of ergometrin and perhaps the first dose of carbapenem, then I'm usually already thinking about a balloon tamponade in terms of more definitive treatment for that patient. So the WHO, of course, has also got guidelines for the management of postpartum hemorrhage and retained placenta, and they've got a nice table in their guideline about drugs. And I think we're all familiar with oxytocin, which is, of course, synthetic version of the hormone. Ergometrin, that's known by different names depending on where you are. I think in Egypt, you're probably more familiar with, is it methyl ergometrin? There's another, I wrote it down, there's another name, methergin, yeah, methergin. But in the UK, we're using ergometrin. They're similar drugs. And then the 15-methyl prostaglandin F2 alpha is carbapenem. And, I think it's just very important to familiarize yourself with the doses, to make sure that they're stored correctly, because of course, oxytocin and ergometrin would need to be in the fridge. And, familiarize yourself with the contraindications. So the most important being really that you don't give ergometrin or methergin to women with hypertension and preeclampsia, and that you're careful in asthmatics with carbapenem. And then also familiarize yourself with how frequently you can give the doses. So with oxytocin, there's no evidence that giving more than 10 units as a bolus would be of any benefit. So, for us, when we're doing a cesarean section, we normally give 5 slowly IV, and then we might give another 5 and then an oxytocin infusion. For the methergin, I think you're giving 0.2 milligrams, and you can give 5 doses. For us, we're giving ergometrin, and it's given as a once-off dose. And then the carbapenem, you can give that, it's 250 micrograms or 0.25 milligrams, and you can give that up to 8 times 15 minutes apart. And that should be really given intramuscularly. There was a phase where people were giving it intramyometrally, and I think that still does stand on the ERC-RCOG guideline, but it's going out of fashion a little bit, and we certainly don't give that, on our label. We would always give the carbapenem, as an IM injection. So just a little bit coming to the end now about tranexamic acid, because that's quite a new and exciting development. And really, there have been several trials about tranexamic acid, but the biggest and the best conducted one was called the Woman trial. And they recruited greater than, so just over 20,000 women, and it was a randomized control trial. And so half of the women received tranexamic acid and half received a placebo. And their main outcome was death due to bleeding, and that significantly decreased in the women that had received tranexamic acid. You can see the relative risk here in the p-value, but that was especially true when the tranexamic was given within 3 hours, within 3 hours of giving birth. And importantly, they didn't report from that huge number of women any adverse effects. So that's led the ERC-RCOG and other national and international organizations to really push tranexamic acid, not only for prophylaxis, but also for treatment of postpartum hemorrhage. So you should give a gram intravenously as soon as possible once you decide you're going to give it. And that dose can be repeated after 30 minutes, and the maximum dose would be 2 grams in 24 hours. So you've heard about balloon tamponade already. It's great that Professor Bakri is with us today. That's really exciting. And of course, you know that there are other forms of balloon tamponade. And I know that, you are using condoms and urinary catheters with the second catheter running alongside as the drainage. But really, balloon tamponade has revolutionized postpartum hemorrhage treatment. We're not doing very many hysterectomies at all now on our labor ward. And most women who have heavy bleeding and are not responding enough to the medical management would be managed on our labor ward with balloon tamponade. And that might be bleeding because they've got a low-lying placenta, or it might be bleeding because they've got uterine atony. But we're managing to look after most of these women and without hysterectomy. And really minimizing blood loss once the balloon catheter is in. I think there was a question in the chat before I started about whether or not you should put a vaginal pack when the balloon is in the uterus. And I think it depends on the situation. So in my practice, if I'm putting a Bakri balloon or any sort of balloon tamponade at the time of a elective cesarean section where the cervix is barely open, and then I wouldn't usually put a vaginal pack because it's not usually necessary, and vaginal packs can be uncomfortable for women, they usually are. But if I'm putting in a uterine balloon, perhaps when the woman is 6, 7, 8, fully dilated, you know, where the cervix will still be dilated after delivery, then I would usually put a vaginal pack. And then we would tie it to the urinary catheter, so it would make sure that we knew it was inside and knew it needed to come out at the time that the balloon was removed, which again varies. Some people will leave a balloon for 6 to 8 hours and some will leave 12, 24 hours. So the individual practice about the length of time the balloon is in the uterus varies according to the unit and according to the practitioner. So my last slides are about secondary postpartum hemorrhage. I wasn't going to include them, but Professor El-Nouri asked me to mention secondary postpartum hemorrhage. So we would define secondary postpartum hemorrhage as where bleeding is happening more than 24 hours after delivery and within 12 weeks. So the most important aspects as defined by the RCOG are that you should, if you're seeing a woman with postpartum hemorrhage, you should assess the hemodynamic status. So what's the pulse, what's the blood pressure, you know, how much blood loss, you know, can you see, what is the patient describing to you, what are her concerns, and importantly, you know, think early about sepsis, because endometritis and retained products are quite common in the secondary postpartum hemorrhage scenario. Your differential diagnosis, starting at the top from most common to at the bottom least common, endometritis, which may be related to retained products of conception. There can be sub-involution of the placental implantation site, and much more rarely uterine artery pseudoaneurysms and AV, arteriovenous malformations in the myometrium, leading to the most important investigations to include. Of course, you should do your usual blood tests for blood count, CRP, etc. But it's very important to think about looking for presence of bacteria, so doing swabs, high vaginal swabs and endocervical swabs, and treating empirically pending those results if you think a woman is infected. And a pelvic ultrasound is really very helpful. And if you're skilled to use the color Doppler, then that would really help you, especially with these more rare, you know, these more rare causes of secondary postpartum hemorrhage. Well, thank you very much. Nice and brief, I hope, but to the point. And this was a photo from one of the last workshops that I did. Well, maybe a few workshops before, it says 2017, but that was in Al Galea Hospital where we did a operative vaginal delivery workshop. And I hopefully coming back to see you again in person soon. Thank you very much.
Thank you so much, Dr. Sophia. We hope to see you soon as well. Thank you so much for this very rich presentation. And actually, we have too many questions. It's just we will pick two for the sake of time. And if you kindly can answer some in the chat, it would be great. Unless we will
keep an eye on the chat. Yeah.
Yeah, and when maybe at the end we take the remaining questions. There are too many questions about the prophylaxis for the high-risk women. If we are suspecting that this lady could go into postpartum hemorrhage, what kind of medication do you prefer to start with? Whether and the dose, the tranexamic acid, can we give routinely carbetocin for the high-risk patients? And there is a trend of using misoprostol pre-cesarean section, just immediately before opening the cesarean section. What do you think about that?
So I did have a slide about the third stage, and I suppose, you know, our practice in Newcastle is based on the, you know, ERC-RCOG guideline, which is very much our national guideline, but there has been a decision that there's no benefit to give carbetocin over and above oxytocin because it's not been proven to be better. So if we're at cesarean section, then we would give a slow intravenous bolus of oxytocin. And if the woman had an identified risk factor for postpartum hemorrhage, like for perhaps she had a fibroid uterus, or she was anemic, or maybe she had twins, then we would give immediately, after cord clamping, we would give 1 gram of tranexamic acid intravenously. Now that's different for a vaginal delivery. I think units in the UK are slightly different. Some are using oxytocin 10 units as an intramuscular injection, and some are using symptometrin, which has got ergometrin and also oxytocin as an intramuscular injection. But you shouldn't give that to women that have got a history of hypertension or preeclampsia.
Yeah. Okay, and the other question is about the doses. Does it differ with the different gestational age? If the patient is like 24, 28, we are using the same doses, yes?
The same doses, yeah. And for misoprostol, actually on our labor ward in Newcastle, we're not using misoprostol at all. I know it's easy, it's cheap, it's easy to have it at hand, and we do use it for putting people into labor that have got an intrauterine demise, for example, as an induction agent, but we don't use it for the treatment of postpartum hemorrhage because we don't believe that the literature supports its use and that these other medications are better. But I think there are still some units in the UK using it, and normally they give 800 4 tablets, 800 micrograms, and either sublingually or rectally, but it would never be given before delivery. It would be afterwards if it's for the treatment of postpartum hemorrhage.
Okay, thank you so much. Thank you so much, Dr. Sophia, for your presentation. Now, Dr. Assam, I pass the word to you, please, again.
Thank you very much, Dr. Rafa, and thank you very much for our great speaker so far. I think the night is getting very interesting and is getting more and more privileged to have Professor Yunus Bakri with us. I've been doing these conferences for 15 years. I never met him, so I'm really privileged to have him tonight with us, and we will have him at the end of the conference for open questions for everybody, if anybody want to ask. Now, we're getting more bleeding, and the patient is bleeding more and more, and then you turn around to look for friends. And the best one, or the first one you will see, is your colleague anesthetist over the blood-brain barrier, as we call it, or over the screen. And then you look at your anesthetist to ask him for help. So now we're having Dr. Will White. He's a senior consultant anesthetist with a special interest in obstetric anesthesia. We just heard he's interested in obstetric hemorrhage, and he's doing this Robin project at the Royal Victoria Infirmary in Newcastle. So Dr. White, we'd be great for your presentation, please. It's all over to you.
Okay. Thank you very much. That's a very kind introduction. Yes, I work at the Royal Victoria Infirmary in Newcastle with Sophia. She's much more youthful than me, so I've been there a bit longer now. I've been there for a consultant there for about 18 years. I also had a year doing an obstetric anesthesia fellowship in Toronto. So I'm going to talk to you a little bit about sort of some themes about resuscitation in major hemorrhage, and what we're going to move right. So I'm just going to pick out some of the epidemiology that hasn't already been covered around obstetric hemorrhage for postpartum. I'm going to talk to you about some definitions and briefly about the causes, and then we'll get on to talking about the resuscitation. So just to go back to, we always seem to go back to this, but it's such a useful tool, but the latest Embrace report, which was for the triennial 2016 to 2018, that's given us, in the UK, we have an overall death rate of 9.7 per 100,000 pregnancies. And we can actually see that hemorrhage is quite low down on the list. In this triennial, only 6% of deaths were related to hemorrhage, which is good news. It's fallen slightly from before. But I don't think it necessarily tells us the whole story when we look at a figure like 6%. So there's something, another confidential audit that the UK has run, which you may be less familiar with, which was the Scottish confidential audit of severe maternal morbidity. So this was run by Health Improvement Scotland. It was a 10-year annual audit, which started in 2002 and went to 2012. And its focus, mainly because the Scottish population is smaller, so has fewer deaths and so is less able to draw lessons from them, looked at morbidity as opposed to mortality. So actually they had a total of 3,475 women who were in the audit, which is actually more women than in the equivalent period for the Embrace report. And the sort of the overall figure showed that 0.14% of all births end up with a mother requiring a critical care admission. And what the Scottish confidential audit shows us a different pattern to Embrace. So whereas hemorrhage is low down on the list of things that result in a maternal death in the UK, you can see that it leaps right to the top when we're actually talking about morbidity. So what we actually spend our time dealing with on a day-to-day basis is much more likely to be problems with major hemorrhage than it is with problems to do with, for instance, sepsis or to do with venous thromboembolism. So overall, in the Scottish audit, there's 61 patients per 100,000 pregnancies suffer severe maternal morbidity. Remember, that's the comparable mortality figure is 9 per 100,000 pregnancies. And also, if you look at what sort of patients end up on the intensive care unit, it showed that in the audit there were 15 patients per 100,000 ended up on ITU. And again, the majority of those are related to major obstetric hemorrhage. The good news is that if you are a mother who's admitted to intensive care, your chance of survival is very high. It's much higher than for most patients who go to intensive care. So it generally is a short, sharp insult, but the patient can recover well if treated. So this point has already been, pardon the pun, laboured. So postpartum hemorrhage is an important cause of death in the UK. It is a major cause of death worldwide, and it is a cause of morbidity. And it's not just the morbidity of the hemorrhage itself, but also of the resuscitation, if that resuscitation is not done as well as it might do. So we just look at very briefly at some definitions. We've already had a little bit of this. You'll see that I'm a bit more pessimistic for the blood volume, but outside of obstetrics, we would generally suggest that a major hemorrhage is loss of greater than 1 blood volume within a 24-hour period, or greater than a 50% blood volume within 3 hours, or blood volume that is occurring at a rate of 150 mils per minute or more. In obstetrics, our definition of a major obstetric hemorrhage at the RVI, well, we all know what it looks like and what it feels like, but if we're just to be precise, we're talking about a blood loss of more than 2.5 litres, or the transfusion of 5 or more units of blood, or the administration of other blood products to help with coagulopathy. This slide has already come up, and it's talking about the physiological changes that occur when a mother loses blood. I won't go over it again, but I just want to highlight that you can lose an awful lot of blood before the patient becomes obviously clinically unwell. But what does come early, an early clinical sign which should never be ignored, is the presence of a tachycardia. You should really look at all tachycardias and try and establish that they are not related to bleeding before dismissing them. Back to the Scottish confidential audit, it showed very nicely what we generally teach our junior doctors, that the vast majority of patients that suffer a major hemorrhage, it is because of the uterine atony, because of retained products, because of trauma, which either vaginal trauma or bleeding from a uterine incision. You notice that abruptions in there, that's part of the postpartum hemorrhage. And also that in the UK in this period, the incidence of morbidly adherent placenta is relatively low, but that's as the cesarean section rates increase, that is becoming more common. If we look at the mode of delivery and patients that suffer a major obstetric hemorrhage, it's worth looking and seeing that the majority of hemorrhage, major obstetric hemorrhage, occurs with operative delivery. So 28% of all births in the Scottish audit were cesarean section, but they accounted for 50% of all the major obstetric hemorrhage. And just to make that perfectly clear, you're 4 times less likely to have a major hemorrhage following a spontaneous vaginal delivery than you are from having a cesarean. So when we get on to managing postpartum hemorrhage, you can't overstate it enough. You've got to treat according to the expected diagnosis. In most cases, it's going to be uterine atony or trauma, and the treatment for that we've already talked about. But we've got to recognize that major obstetric hemorrhage is a life-threatening emergency. And the cardinal aim is to arrest that hemorrhage and replace lost blood. And it's crucial that both these strategies are pursued simultaneously. There's no point just going on and trying to stop the bleeding if the blood loss is so high that irreparable damage is being caused before that occurs. I just wanted to highlight again from the Scottish audit that Sophia's mentioned this too, but in Scotland, they were identifying 80 to 90% of patients who were high risk, but action plans being completed and followed only occurred in 50 to 70% of those high risk women. And so the importance of identifying your patients first. Volume replacement, again, as said at the beginning, we should be looking at not overdoing resuscitation with clear fluids. So the recommendation is 2 liters of crystalloid and maybe 1,500 mils of colloid, although I have to say in the UK, we've moved away from colloid in the last 5 to 10 years. And data just from the 2012 version of the audit, it showed that there's a significant proportion of those patients who require ITU admission is because they've had too much fluid as part of too much clear fluid as part of their resuscitation. Also, it's interesting to note the surgical treatment has changed during this audit between 2003 and 2012. In 2003, 15% of patients with a major obstetric hemorrhage were getting a peripartum hysterectomy, and that dropped to 5.9% in 2012. And I imagine this has dropped considerably further because of the introduction of intrauterine balloon tamponade and uterine compression sutures, which really have transformed the treatment of major obstetric hemorrhage. One of the important things you need to have in place for your treatment of hemorrhage is having a major hemorrhage protocol in terms of blood and clotting replacement. Now, we have, when we have a major hemorrhage, we ring the lab, we declare that there is an ongoing hemorrhage, at which point they will immediately send us a box of blood products, and they will keep sending us boxes of blood products until we ring up to say that it's stopped. Until recently, identical to all the major hemorrhage protocols in the hospital, the first box had 4 units of red blood cells and 4 units of FFP. The idea is you give them 1-to-1, 1 of red blood cell, 1 of FFP. The second box added in a unit of platelets. The third box pooled cryoprecipitate. And the ongoing boxes would alternate between platelets and cryoprecipitate as the added blood product. But these protocols are actually developed largely on the back of trauma and largely on the back of military trauma. And we know that that is obviously a very different patient population. An interesting paper was published in 2014 in Blood, which tried to look at what was more relevant in the obstetric population. So fibrin-based clot formation as an early and rapid biomarker for progression of postpartum hemorrhage. So this study was an observational study. It recruited patients when they had a blood loss of 1,500 mils. At that point, obviously their resuscitation continued, but they were they had blood taken. They had blood taken for clotting, for hemoglobin. They also had blood taken for a ROTEM, which is a type of thromboelastograph, to look at the FibTem, which is a marker for the fibrinogen level. And then they just merely observed what happened to those blood parameters as the hemorrhage continued to its conclusion. So the conclusions of the study were fourfold. The first thing to say was that the FibTem, which is the measure of fibrinogen using the point of care testing, the ROTEM machine, was a reliable surrogate of the fibrinogen level. So when you send your bloods off to the lab for your clotting, you get a very reliable result, but unfortunately the delay in getting that result is often up to an hour, and in a fast moving, fast changing situation of postpartum hemorrhage, that is sometimes just not good enough. So having point of care testing, you can get a reliable result at the bedside within about 50 minutes. The second conclusion was that the normal fibrinogen in women who are having an ongoing PPH beyond 1,500 mils is greater than 2 grams per liter. In fact, the mean was 3.8 grams per liter. The third conclusion was that if the fibrinogen was normal, then the rest of the coagulation was not deranged. And so fibrinogen is a good marker, as good a marker of your coagulation as anything. The final conclusion was that they did have a small subset of patients who presented with a low fibrinogen, and these patients seemed to go on to bleed more, sometimes much more, and were often associated with placental abruption. So what are the implications of these conclusions? Well, the first thing is to say that most obstetric patients having a PPH have normal, or actually more accurately, supranormal coagulation. And most obstetric patients only need red blood cell resuscitation at the beginning of the resuscitation. If patients present with an impaired coagulation, they may well go on to bleed more, but unless that is corrected early. The second implication is that that one-to-one red blood cell FFP protocol that we were using is probably inappropriate in obstetric patients, and we are actually diluting the fibrinogen because FFP fibrinogen concentration is lower than the patient themselves. And you're giving them more fluid, you're risking fluid overload and pulmonary edema in these patients. Also, one of the focuses was whether maybe resuscitation should look at identifying those patients with a low fibrinogen and maybe give them fibrinogen replacement as part of the resuscitation. That went on to be the OBS2 study, but unfortunately it had an inconclusive result due to an inability to recruit patients. So with that in mind, I'm just going to outline a few strategies for major obstetric hemorrhage resuscitation. So pre-delivery, we've already talked about it. Identify your high-risk women, optimize their hemoglobin levels, measure the blood loss. Estimation, as we've said, is notoriously inaccurate and usually an underestimation, and ensure the staff are trained and know when to escalate. So hopefully that'll be your starting point before you get a patient presenting. When you have got a patient presented with major obstetric hemorrhage, you've got to identify them early and you've got to escalate the care early. And it certainly helps if you have very rigid protocols on this. Avoid over-resuscitation with clear fluid. As a general rule, no more than 3 liters of clear fluid in a 1-hour period without starting blood. In your major hemorrhage protocol, for your boxes of blood, the first box should just be 4 units of red blood cells. Then onward, as the patient, you start to dilute the patient as part of your resuscitation. Then you add in FFP and platelets, cryoprecipitate. However, as part of your resuscitation, you should be trying to use point of care testing as much as you can. So point of care hemoglobin measurement, we're aiming for a hemoglobin of greater than 8. That's higher than is recommended in hemorrhage treatment outside obstetrics. But one thing we know about obstetrics is it's sometimes very difficult to say that the bleeding event is over. Sometimes it can restart, even though you think you've done it. Point of care coagulation testing. So using a ROTEM or another type of thromboelastograph to guide the efficacy of your clotting factor replacement. And often what that will be telling you is that you don't need to give them FFP. And point of care venous or arterial blood gas analysis using a lactate to guide the efficacy of your resuscitation. Just briefly, I am an anaesthetist. I have to mention something about anesthesia itself. How do we actually manage these patients when they have to go back to theatre? The problem with major obstetric hemorrhage from a surgical management point of view is that it's unpredictable. The intervention could be just a simple D&C or maybe a suture, or it could be a laparotomy and a hysterectomy. So the anaesthetic that you choose has to be flexible enough to cope with this range, and the plan can change anytime unfold. So regional anaesthesia is what we are always trying to do from a safety point of view from the patient, but it has its challenges in major obstetric hemorrhage. Or spinal and epidural anaesthesia produce a profound sympathetic block, which will get vasodilatation, and in an under-resuscitated patient, you could get profound hypotension, and as a result of reduced return to the heart, it could go on to loss of cardiac output. So spinal anesthesia will only be considered if you're taking that patient to the theatre for a surgical intervention if the blood loss is either relatively modest or if the patient has been adequately resuscitated prior to starting the procedure. Epidural top-ups, if you've got an epidural in labour, they do cause less hypotension, but as a general rule, you still are going to be cautious. General anaesthesia is generally safer in the presence of hypovolemic, but that doesn't mean you shouldn't be resuscitating the patient as you go along. You can get profound hypotension on induction of general anaesthesia as well. However, a lot of these patients may well present during caesarean section, as we've already alluded to, and so they are likely to already be under regional anaesthesia as events unfold. You can manage major obstetric hemorrhage with an awake patient with the use of fluid or blood replacement and vasoconstrictors, but you may have to convert to a general anaesthesia. One of the problems is if you're failing to keep up with blood loss, you can get reduced cerebral oxygenation, cerebral irritability, and an uncooperative patient, and it's safer to get that patient to sleep often. Now, after the bleeding has been stopped, most of these women will recover very quickly. That once the tap's off, if the resuscitation has been good, then the patient often looks remarkably well, even with very high blood loss. And what you're looking for as the signs of a successful resuscitation is get that tachycardia down, get a normal blood pressure, normal oxygen saturations on room air. You're guided by the blood lactate. You want less than 2 millimoles per liter as a sign of good end organ perfusion. You want normal urine output, and you want normal body temperature. Why might you end up going to the intensive care unit? Well, if they're in the presence of potential end organ damage, they are much better looked after by the specialists in intensive care. This can happen if you're just not able to keep up with that blood loss. Blood gases may indicate that the lactate is high and is not coming down particularly quickly. Urine output may be low. The patient may be displaying signs of cerebral irritability, or the patient may need inotropic support to maintain blood pressure. And just one final thing, morbidity related to the resuscitation itself. Pulmonary edema secondary to fluid overload is more likely in pregnant women than in the non-pregnant population. They are very sensitive to fluid overload, and that becomes more so if you start to dilute them with larger volumes of clear fluid. You can also get transfusion reactions from acute lung injury, which is not well understood, but it can lead to, both of these can lead to you needing prolonged positive pressure ventilation and potentially develop ARDS. But that's it. So thank you very much.
Thank you very much, Dr. White, and a very good presentation and very helpful for the obstetrician to know that there is a friend on the other side of the table. So I got few questions. I think you might answer some of them, but I just got that from Dr. Gamal Ahmed. There is increasing dependence of anesthetists to utilize ROTAM to reduce giving FFP and platelet, irrespective of the blood loss. What is your view about that instead of giving blood, platelet, and fibrinogen 1:1:1?
Yeah, so I think the evidence is quite clear that at least in the initial part of resuscitation, you have the majority of your patients will be have a normal coagulation or supranormal coagulation. They won't need FFP. They will just need replacement of the blood the replacement of the hemoglobin that they have lost. As hemorrhage is ongoing, though, if you start to get beyond 4 units of blood, then it becomes less predictable. And the point of care testing with ROTAM certainly allows you to get a timely answer on whether the patient is being adequately resuscitated from a coagulation point of view. The lab tests are the most reliable, but we really can't guarantee getting those rapidly enough to deal with the patient in front of you. So first 4 units of blood is without FFP. Once you get beyond, then as a general principle, 1:1 blood and FFP, but you can be guided by your point of care testing.
Thank you very much. As the second question, as the tab is opening now with the loss of a lot of blood, and the patient is losing quite a lot of blood. Now, replacing the blood volume, first question, do you have to use a blood filter or not?
So we do use a blood filter, so we'll change our fluid giving set from a standard clear fluid set, which doesn't have a filter. We will change it to a blood giving set which does have a filter. These filters are really getting rid of large debris that may be in the packed cells. It doesn't interfere particularly with the speed that you can give that blood, and you can pressurize blood through a filter without damaging it. Yes.
The second question and last one is, do you use a cell saver routine for patient with elective or even emergency cesarean section, or do you only use it for patient with massive bleeding?
So actually, we don't use it for either. In the past we looked into it. The problem with using a cell saver is that it can be useful in retrieving blood and giving that blood back to the patient. But in the presence of major hemorrhage, you have problems with the speed that you can collect it and the speed that you can process it for giving it back. And what that means is that you really can't replace the volume in major obstetric hemorrhage very easily using a cell saver. And so even if you use it, what will tend to happen is that you'll be giving 4 times more packed cells from the blood bank than you will actually giving back the blood from the cell saver. The only indication where we really do think it remains useful is if the patient is unable to accept blood products, donated blood products, such as, for instance, Jehovah's Witness, and then we will always use a cell saver. But that is only because there is no choice.
Thank you very much, and we are very grateful for your presentation. And now back to you, Dr. Wafa. Thank you very much.
Thank you. Thank you so much, Dr. White, for your valuable presentation. I'm delighted to present our next speaker, Dr. Mohammed Alem. Dr. Alem is a consultant OB-GYN, NHS Lancashire, and honorary senior lecturer at Glasgow University. He's going to talk today about the surgical management of postpartum hemorrhage, the compression, tamponade, and the tips for cesarean hysterectomy. Dr. Alam, please.
Thank you for this nice presentation, Dr. Wafa. I would like to thank Professor Salam and the organizing committee for inviting me to this nice webinar. So this is the say of one of the obstetric registrars who now left the specialty totally. In obstetrics, you experience huge highs, but also the worst lows. Things do not often go wrong, but when they do, it is. Now, this is just was the final straw for him before he left. The final straw came during the hellish shift when I performed an emergency cesarean section on a woman with an undiagnosed low-lying placenta. The baby was stillborn and the mother lost 12 liters of blood. I was told to fear the worst. I'm sure lots of my colleagues from the UK will know him, Adam Kay, and I would really advise you to read this book, which is a very nice book. So we all know the intraoperative measures to limit blood loss, and this has been spoken about heavily during these talks. So let's go to the surgical management straight. The first step when the tummy is open, maybe is internal aortic compression, which is really very easy and quite effective. How do we know that we are doing it right? We feel the femoral artery and we find that the pulse on both sides are stopped or less. Then in this case, we know that we have blocked the aorta. It is easy. We just feel the bifurcation, and because of the laxity of the abdomen during the pregnancy, it is actually fairly easy to do. Now, what about prophylactic surgical measures like the compression sutures, internal iliac ligation, and etc. Before doing the hysterectomy? Are they really effective? And we can resort to them quite early, especially in third world country when continuous flow of blood and FFP is not really available. The answer is yes. As we can see, all the measures which are not hysterectomy, like balloon tamponade, uterine compression, internal iliac artery ligation, are all very effective, mainly and especially if they are done timely on the right time. Now, starting with Professor Salah Abdrabbo from Alexandria, he published his stepwise uterine devascularization in the Green Journal in 1994. It is a very simple, easy technique and quite effective as well. By stepwise ligation, the blood supply of the uterus, which we can see it is very extensive. However, we can try to close the main trunks of the blood supply to the uterus, stepwise from the uterine to the ovarian side, and the results are quite promising. So internal iliac artery ligation is quite an old operation, used to be done in advanced cervical cancer in the 1890s to reduce blood flow to the pelvis. And this may reduce our hysterectomy rate by 50%. So some anatomy, we know that the bifurcation of the aorta will happen between L4 and L5, and this will give rise to the common iliac artery, which on its turn divides at the sacroiliac joint to external iliac artery, which goes straight to the lower limb, and internal iliac artery, which we are going to speak about shortly. So another important point in this technique is to how to find the ureter, which is really simple and easy, especially in obstetrics patients where glands are quite easy to dissect. We just open the round ligament and then open the peritoneum, cephalad for 10 centimeter. We will find the unmissable external iliac artery, which is a big pulsating vessel on the pelvic side wall. Just follow it up till the bifurcation, and the first structure you find sitting on the artery is the ureter. Now, this is a cadaveric specimen. We can see here the bifurcation at the junction of L4 and 5, common iliac artery dividing at the sacroiliac joint. This is, by the way, a very common question in the first part, especially in surgical specialty. So we have the external iliac artery here, and this is the main trunk of the internal iliac artery. Now, where exactly should we tie this trunk to avoid problems and make life easy for ourselves? So going out of the bifurcation, the trunk after 1 to 2 centimeters will give the posterior branch, which is divided into iliolumbar, lateral sacral, and superior gluteal. And also we can see this sneaky structure here, which is the internal iliac vein. The internal iliac vein actually is very close to the main trunk when it starts here. So ideally, we should put our ligation in this area about 4 to 5 centimeters from the bifurcation for 2 reasons. To avoid the posterior trunk and avoid obliterating the branch, which is the iliolumbar branch here mainly, and also to avoid the posterior sneaky structure with the internal iliac vein, which tend to separate or be a little bit further afield from the internal iliac artery after 1 or 2 centimeters from the bifurcation. This makes life easy when we dive behind the artery. And this is how we do the procedure. We're using a Leahy or right angle clamp to ligate the artery 4 to 5 centimeters from the bifurcation, sneaking between it and the internal iliac vein with one ligation. We do not transect or bisect the artery, just a simple vicryl suture will do the trick. So this is a video which is short and crisp. I got it for you from the internet. I hope it will work.
Internal iliac artery ligation for PPH. Abdomen opened by funnel steel incision. This is the internal iliac artery and separating the fibroareolar tissue on either side with forceps. This medial side, this is on the lateral aspect. You must be very careful, especially when dissecting on the posterior aspect. Vein will be underneath. Now thread with number 1 vicryl. Now ligating the internal iliac artery with vicryl. After that, I will check it with pulse oximeter. This is the ureter. One can appreciate the peristalsis. This is the psoas muscle with genitofemoral nerve. This is the external iliac vein. This is sacral promontory with the median sacral vessels.
So yes, there are complications, about 1 to 10%. For example, incidental ligation of the ureter or the external iliac artery, which can cause big problems for the lower limb, spasm and thrombosis, necrosis of the buttock if we ligate the superior gluteal, perineum and bladder mucosa necrosis as well, circulatory disturbance of the lower limb, and some studies showed a reduction in AMH. So this is a picture of an unfortunate lady who had a incidental ligation of the superior gluteal vessel, and this needed plastic surgery with flap to cover the necrotic area with fairly good results. So it is very difficult to speak about B-Lynch suture in the presence of the man himself, Professor Lynch, and also Dr. El-Hammami, who is an international figure in this technique. However, I will do my best, and please let me know if I missed anything. So the B-Lynch sutures means the classical and the transverse B-Lynch sutures really were game changers in the obstetric specialty. And as was said by Dr. White before, that the hysterectomy rates are much less now, and the B-Lynch sutures were one of the contributing factors. Because of all these reasons on the screen: it saves lives, it saves fertility, simple, quick, reproducible, and cheap. So the idea came to Professor Lynch in 1989 during a massive PPH for a lady who was really refusing hysterectomy. So the idea is very simple. It is really moving from trying to block these vessels at the origin and go and work on the end arteries here, or the terminal branches here, by blocking the blood supply to the placental bed, which is the main problem. So these are the pictures from front, back, and final picture of the classical B-Lynch suture. As you can see, it is really compressing all the terminal branches of the uterine arteries. So this is a close-up with the distance and anatomical landmarks that you are going to use to apply the suture. And this is a live picture from Professor Lynch as well, front view and posterior view. Now, the suture material that we are using now is monocryl #1, 90 centimeter suture length on a 70 millimeter blunt needle of half circle curve. Other compression sutures have also been described, like the multiple square and the Haemorrhage suture, with various success rates. Now, in Lanarkshire, we had the problem of teaching trainees in emergency situation, and I'm sure most of us has got this problem as well, teaching trainees and colleagues on in an emergency situation. So we came up with the idea of in vivo low-cost model using pig's bladder here, as you can see, which is simulating the uterus very much, the bladder here, mesentery, and bladder neck, ureters, simulating the uterus, tubes, and cervix, and broad ligament as well. The other specimen that we used, which is the wet specimen, is the bovine uterus. You can see the uterine body here, the cervix, the bladder, and mainly the uterine vessel. And please concentrate with this because we are going to use it for later for transverse B-Lynch, and you can see the broad ligament as well. So now this is a video of our specimen that we are using for regular training now for simulating the B-Lynch suture on the uterus with a cesarean section opening. So we can see here we do the cesarean section incision. I'm doing here with scissors for facility only. Now we can see that we are taking the first entry 3 centimeter from the lower edge, and then 3 centimeter also from the upper edge, and then on the fundus, up on the fundus and back at the level of the uterosacral ligament into the posterior wall. And needle is out now, as we can see, back into the posterior wall at the same level, but from the other side, other uterosacral ligament, then back on the fundus, and same level on the upper segment, just above the upper border of the incision, and then again 3 centimeters, same level from the other side. Now we have, because we have this 90 centimeter suture, we can do the compression with the assistant while we are working on the cesarean section incision without any problems. And then we close the incision. We close the incision and then we tighten the knot, and we don't tighten against the body of the uterus, but we compress with manual compression and then tighten the suture. Obviously, we need to make sure that the uterus is empty and no tears before doing this procedure. Next, lots of questions from trainees were asking about how do we do the village suture on a closed uterus if we have to open the abdomen after an atonic PPH without cesarean section. And we also replicated the technique here on this pig's bladder. So we can see here the bladder is like uterus exactly. So we do the pre-application test first, make sure that there are no tears and no contents, placental remnants, placental cotyledons. And then we dissect the bladder properly, and imaginary line of the cesarean section. We take a deep bite and over the fundus, go from the back, go deep between the two uterosacral ligaments, above the fundus again, and then again from the front, and then again from the front at the same level, but from the opposite side as well. Then we have the same picture as the original village suture, and we tie the knot, not against the uterus, but after by manual compression with the assistant. So transverse village, this is much less published and much maybe less understood by trainees and maybe colleagues, as it is a little bit more complex than the classical village. So what is the idea exactly? It is the same. We want to obstruct the blood supply at the terminal branches of the uterine and vaginal arteries. So how are we going to achieve that? So basically, we would like to obstruct the vessels at this level here, and also compress the lower uterine segment, which is bleeding, especially with placenta accreta. Now, that's very good. However, we have here in our way to reach this vessel, the broad ligament with its contents, which is the adnexa and the ureter as well, and the main stem of the internal iliac artery. And this is basically a tiger leg. So you really don't want to go around this with your suture and crumbling everything towards the uterus. So how are we going to reach this goal without crumbling and affecting, compressing the ureter and the adnexa and upsetting these big vessels here? Let's see. This is also, this is the bovine uterus that we mentioned before, and we published this also, this technique. This is now the big vessels at the side, broad ligament with the ureter, etc. Now, bladder is dissected during the cesarean section. Cesarean section is open now. We can see the bovine uterus is completely didelphys. So we start with, as Professor Lynch indicated, with the back wall. Basically, all the piercing will be in the posterior wall of the uterus, all the piercing, apart from one, and I'll tell you about it now. So all the piercing in the uterus needle. So we start with posterior wall. Now we can see the needle is anterior, and the tail here without the needle is posterior. So carry on. Now we want to get the tail anterior because the final tie will be here anteriorly above the upper border of the incision. So against light and with a mosquito, we take the tail of the suture of the monoclel and bring it against light in avascular area, very near to the vessels and the uterus, to the anterior aspect of the uterus. Now, we have this tail in the anterior aspect, and we will go 3 centimeters below the lower edge of the incision. This is in the posterior wall, and then the needle will go posterior. We bring the needle again through the broad ligament near to the vessel against light anteriorly. Now we have 2 monocryle anteriorly. The next step, which is only, you can see here, now this side is completely compressed at the moment. Now, this is the only bite with the needle that we take in the anterior wall, just to avoid slipping of the monocryle. Now we go through the broad ligament now, because we are aiming to have another attack with the needle, another pierce in the posterior wall at the same level of the lower entry from the other side. This is now piercing the broad ligament. In avascular area, you can see the needle here coming and out. Now we are attacking the posterior wall at the lower level, same as the other side. Now the needle is coming out through the incision, and we have pierced already the posterior wall. This is at the lower level. Now we want to go the last bite or the last piercing of the uterus at the level of the upper entry, which is the first one that we have done. You can see, sorry. So we can see here, this is again, so the posterior wall. And the last bite in the uterus to the posterior wall. Now we have a problem. We would like to tie, as we mentioned, in front, above the upper border of the incision. We are going back through the broad ligament here, against light, through the avascular area, and then leaving all this broad ligament with all its contents with the tiger gland. Now, as we can see here, the 2 ends of the threads, this is the thread with the needle, and this is the thread which is with the other end with no needle. And now we are going to tie above the upper edge of the incision to compress both arteries or both vessels from the both sides, and compress the lower segment as well. Okay, and this is the end of the procedure. Now, we have done, I didn't find any peer-reviewed publication about the transverse Billich suture. We have done 10 cases in Alexandria University, and had an oral presentation. Professor Ahmed Fawzi Jalal presented it in the FIGO. The suture itself took about 5 minutes, and we had 1 out of 10 who needed hysterectomy. This patient had previous 4 cesarean sections. There was another study also from Egypt who had 23 cases, which was published in the Green Journal, and the conclusion of both studies was almost the same, that the technique is reproducible and can be easily taught and very effective. So now we come to the hysterectomy, although it is not very common. However, when it comes, then we need to be ready for it. So we have total and subtotal hysterectomy. Subtotal hysterectomy is used in unstable patient and when cervical removal is not needed for hemostasis. In the UK, the rate of peripartum hysterectomy is about 4.1 per 10,000. So in a 5,000 delivery hospitals like University Hospitals, Lanarkshire, we have maybe 2 or 3 only per year. Maternal mortality is less than 1%. So things to consider during cesarean hysterectomy, the anatomy is a bit distorted because of the enlarged uterus and everything is edematous. The pedicles are really large and edematous. So a tip here is to take small bites, because large bites will protect the artery or the vessel in the middle of the pedicle from your thigh or from your ligature, and then it will keep bleeding because it has not been occluded properly. So take a smaller bite and orient yourself, correct orientation, because when you put the clamps on a long pedicle, it tends to twist. So make yourself oriented of the anatomy and the proper orientation of the pedicles. Double clamp the pedicles because to avoid also backflow, because as we know the blood supply is very rich here, and also avoid taking the ovarian ligament too near to the ovary, because this can lead to oophorectomy because of the injury to the ovary itself. Also, we can use delayed clamping technique by applying the clamps and cutting the pedicle, so we can stop the blood supply and isolate the uterus. Then we can remove the uterus after that. So be aware that the bladder might be adherent. It might be difficult to identify the cervix. So identify the cervix and the vaginal fornix. Then, especially with a full dilatation, cesarean section. So be aware that you need to identify the fornix to be able to open the vagina and do a total hysterectomy, or remove the cervix if the lady goes back to theater after subtotal hysterectomy. The tissues might be very friable, so handle with care. Be aware of uterine tears, especially after full dilatation cesarean section, because lateral extension can go into the lateral pelvic side wall, and there is risk of ureteric injury, either by the tear extended itself or by taking sutures in such a tiger lamp. So early resource to hysterectomy is recommended if conservative medical and surgical intervention have not been successful, and this is the ERC-RCOG Green Top Guideline recommendation from 2018. So we need to be very careful about the timing of the hysterectomy, not too early and not too late. Of course, the timing will change according to the country. If you don't have a good blood supply from the bank, then in this case you need to resort to it early to save the patient's life. However, you can try to resuscitate and use other conservative measure if you have good blood bank and blood supply resources. So what are the surgical concerns of the current techniques for the total cesarean hysterectomy and removal of the cervix after return of the patient to theater with bleeding after subtotal hysterectomy? Now, the current technique warrants more surgical dissection into the depths of the pelvis to reach below the cervix. The disturbed anatomy, especially with previous surgery, in the uterovesical and Douglas pouch can be a real problem. The need to dissect the ureter and pelvic side wall in a patient which is really critically ill. Possible unnecessary increased operating time in this particularly ill patients as well. So you need to perform the procedure as fast as possible. Hence, you need to really reduce your dissection. So increased risk of bleeding with dissection, of course, because this very vascular area, and this can lead to infection and complication especially ureteric injury and major vessels injury when we cannot see really the plans very well. Also, in these young ladies, removal of or injury or trauma to the upper part of the vagina with such a large cervix in a sexually active woman can be a problem. So, yes, yes, Dr. Al-Hamami, this is a laparoscopic hysterectomy, and this is a gynecological procedure, and no, it is not put here by mistake. So as you can see here, let's think together why I did put this video here in an obstetric webinar. So what can we see here? This is the uterus. First thing, the uterus is into the abdominal cavity, far away from the tiger land of the pelvis. The other thing is, as we can see here, the bladder is just 1 centimeter away from the vaginal fornix. So very minimal dissection of the bladder is needed in this total laparoscopic hysterectomy. Also, you can see the uterine pedicle here, which is only 0.5 to 1 centimeter from the edge. So basically, we are cheating here. We have done a subtotal hysterectomy dissection to achieve a total hysterectomy and remove the cervix. So our group in Lanarkshire, we thought about using this technique also in open surgery. As we can see here, the fornix is nicely open, very high on the cup of the manipulator. This is the green cup of the uterine manipulator for those of you who have not seen this procedure before. So now the procedure is almost complete. The uterus is going to be removed, and we did not do very much dissection here at all. So our group in Lanarkshire, we published this technique in open complex gynecological hysterectomies, and we thought, why can't we use this in obstetrics as well? And we published this technique also. Now, this is the cesarean section. This is a bovine uterus again. Now, if we put our finger into the cesarean section incision and lift the cervix up, then we can really easily identify the fornix here. And this is the bladder, only dissected just 1 centimeter below the incision edge. Now we open the fornix on our finger, and you can see here minimal dissection of the bladder and the uterine vessels. The uterus or cervix is very high up in the pelvis, far away from target land. No need for any further dissection of bladder, ureter, or bowel from behind. All what we need to do is to circumflex incision here, just on the fornix, around and below the cervix, which is already in our finger here. This is the fornix now being opened between 2 clamps or with ligature if you have, and then clamp and tie these pedicles one after the other. And this is the cervix in your hand. The vagina is preserved its length, and there is hardly any dissection for the bladder or from posterior. And now the uterus or cervix is removed, and then you just have to close the vault. So it is really very simple technique, and we have done quite a few. Maybe I have done personally about 3 here in Lanarkshire with a very nice results, and also Professor Galal have done quite a few in Shadby Maternity University Hospital in Alexandria. So we have also created here this a dry model, and beside this wet model, and the tool or the questionnaire to the trainees showed very high satisfaction rate and very high intake of the steps of the procedure with these models. This is our plastic model, which is very simple. just a saline, 1 liter saline bag, which with its plastic cover, you just open and mark your uterine incision here. This is the bladder basically. And all what you need to do is to put your finger in, bend your fingers, and will come here on the fornix and then open this area here. And this will be a circular incision around the cervix. So this will be removed, the bag will be removed, and or the cervix will be removed, and with very, very minimal dissection of the bladder here. And this was tried and tested in our courses that we do in Lanarkshire for the west of Scotland trainees. So what is the benefit of this technique? So lifting the cervix and uterus out of the pelvis will get you out of this tiger leg. There is no need for dissection of the bladder, or especially the Douglas pouch when it is closed. The bladder dissection with previous cesarean section, adherence and all is only 1 centimeter below the edge of the incision. The vaginal fornix is easily identified with even with edematous tissue, full dilatation, etc. There is much less dissection, as we mentioned, in the Douglas pouch and for the bladder, and much less blood loss, trauma, and much less time for the operation. And we also preserve the vaginal lens. At the end, I would like to thank Dr. Evelyn Ferguson, Dr. Hasseb, and Dr. Mihai Gergely, and from UK, and Professor Ahmed Fawzi Galal from Egypt for helping me to put this talk together. And thank you very much.
Thank you, Dr. Alam, for the very practical and illustrative presentation. We will just take a couple of questions from the chat. We have many actually. Maybe 2 related questions about the using the B-Lynch as prophylaxis. If we have a floppy uterus is not contracting but not bleeding, or again, if we just assuming this lady may have postpartum atonic postpartum hemorrhage because of polyhydramnios or multiple pregnancy or so on, can we use compression suture for prophylaxis?
I did ask Professor Lynch this question about 20 years ago, and he actually agrees that we can use it as prophylaxis. I think we should really use it, especially in countries with low resources of blood supply. So if you don't have blood resources, it is better to resort early to the B-Lynch suture, especially in high-risk cases, to prevent the postpartum hemorrhage to aggravate and then go into an area which is like disseminated intravascular coagulation, etc.
Okay, thank you. And there is many questions about when to do what. The Bakri balloon or any kind of balloon, the pre-sutures. If we have a cesarean section and vaginal delivery, placental site bleeding in different situations, what step to start with and what comes next?
Thank you for this question. It is actually a common question that are asked by many people. The problem here is that we need to classify what exactly we are doing for what and what do we want to achieve. So we cannot compare an invasive procedure like the B-Lynch suture, which is done just before the hysterectomy to avoid hysterectomy, with a conservative management like a Bakri balloon. So if you have a vaginal delivery and we have an atonic postpartum hemorrhage, then of course you need to resort to the balloon first. The invasive procedure, including laparotomy, internal iliac ligation, B-Lynch suture, hysterectomy, etc., are only a second step after exhausting all the measures to avoid laparotomy.
And there is a last question about the efficacy of triple ligation, which consists of round ligament and uterine artery ligation at 2 sites under the cesarean section level and at the level of the ovarian uterine anastomosis.
Sorry, I couldn't.
Just ligation the tube ovarian putting compression on the tube ovarian and uterine as a prophylaxis before, in order to minimize the bleeding before delivery of the baby?
Well, to be honest, I do not have experience in this, but I mean, what Professor Abdrabbu explained in his stepwise devascularization of the uterus was to treat the hemorrhage rather than prophylactic against the hemorrhage. So I do not have experience in doing stepwise devascularization of the uterus as a prophylaxis really.
Thank you so much. Dr. Nouri, would you like to answer this question, please?
Can you repeat it again, please?
Yes,
Dr.
it's about the, because I know that I've attended a beautiful lecture about that said by yourself, trying to have the tube ovarian or intraductal pelvic compression and uterine compression before delivering the baby. Can you just give us an idea about that?
No, you mean in case of placenta accreta and previa? Or?
Yes. Yes.
No, no, what we do, we deliver the baby first, and immediately and before delivery of the placenta, we apply a occluding non-permanent vascular clamp to the infundibulopelvic ligament. So we lift the tube and ovary medially, and we externalize the uterus, of course, so you can see the infundibulopelvic ligament easily, and you apply a Satinsky vascular clamp on either side. So you, in this case, you stop the ovarian blood flow, and then with compression from an assistant at the back of the uterus at the level of the uterine vessels against the symphysis pubis, you reduce the blood flow from the uterine. Sometimes you can apply the Satinsky vascular clamp at the side wall of the uterus. In this case, you have time for the placenta to separate, hopefully, and if it does not separate, you can try to negotiate it and remove it. As long as you don't have severe bleeding, then in this case, you can separate the placenta. What happens during that time, when you control the bleeding, the lower uterine segment become thicker and retracts more, so you can actually separate the placenta. The problem in placenta previa or accreta, that sometimes the lower segment is very thin with previous 2 and 3 and 4 cesarean section. So if you try to deliver the placenta immediately with the very thin lower segment, it will tear more and you will get trouble in bleeding. So if you can control the bleeding by either intra-arterial balloon, which is very expensive, or by vascular temporary occlusion of the infundibulopelvic ligament and the uterine vessels, then you can have the time for this lower segment to become thicker and retract, so you can negotiate the placenta. And if you fail to negotiate the placenta, you can actually just resect the area which is usually at the scar level of the previous cesarean section and reconstruct the uterus again and apply one of the compression sutures for the lower segment uterine incision, as Dr. Muhammad Allam revealed. Thank you.
Thank you so much, Dr. Professor Amr Nouri. Thank you, Dr. Muhammad Allam. Thank you so much, Dr. Assam. The word is yours now for the questions and answers, please.
Thank you very much, Dr. Allam. It was very educational. I really got a lot of points out of this presentation, and thank you very much for that. So we're going to conclude the webinar now by having all our speakers on the screen, please, and question time will be open. We have some questions from the chat, and if you can have all the speakers up on the screen, please, including Professor Yunus Bakri, please. Dr. Mai, can you hear me?
Yes, everybody's on the screen, Professor Assam. Your screen probably you don't have, you can put all the speakers on the screen, but everybody's on the screen, including Professor Yunus Bakri, who's waiting for whatever you wanted to ask him. And
Professor Bakri, it's a great pleasure to have you with us tonight, and
Thank you
very much.
Can you hear me?
I can hear you very
Thank
well.
you.
Thank you.
I will not, I already asked one question, and I'm not going to take the time of the colleagues, but I'm going to ask the same question. My question about the ACRETA, PERCRETA, was not about ACRETA or PERC or INCRETA. It is about PERCRETA with bladder wall invasion. It is the problem of the obstetrics globally. The PERCRETA with bladder wall invasion or parametrial wall invasion is a huge problem which kills. Now, there are two approaches. Do nothing, leave it alone, let it regress, then come in 4 or 5 weeks and reassess and do a delayed hysterectomy. The other option is do it on the spot. Just ironically, while you are discussing other things, I have in my kitchen, I looked at this article. It's from Baylor University in Texas, and it is by prominent gynecologists in the States, obstetricians. It is, I'm sure you have read it. It's a case report, aortic compression and cross-clamping in a case of placenta PERCRETA and amniotic fluid embolism. Now, amniotic fluid embolism is now a wastebasket diagnosis in the US. The obstetricians who end up with major morbidity or mortality from PERCRETA with bladder wall invasion, they give it to the lawyers. The system in the UK of confidential inquiry is the only system which is right, and it's the only country which has an inquiry perfect. The United States is 100 years away and backward when compared to the UK. Everyone, if you do not cover up for your cases which end up bad, you will be fired in the US, because who determines the outcome of your morbidity and mortality? It's the lawyers. Unfortunately, the confidential inquiry, you cannot do it in the United States because it's not a federal issue. So the state of Pennsylvania, the state of Utah, state of Washington, state of this, state of that determines about their own confidential inquiry. So this is my question. PERCRETA with invasion, do you do hysterectomy now with the problems and mortalities like this case, which ends up with wastebasket amniotic fluid embolism? Now, amniotic fluid embolism in the US is skyrocketing from situation like this, and it's case reports, and I don't know what to do. I know what to do. Which state I am working with, and I will comply with the rules of the hospital. You are lucky in the UK because you have a system which I don't know how many years now, maybe 30, 40 years, the confidential inquiry. And the question about what do you do in Egypt? I really don't know what you do in Egypt for percreta with the P and bladder wall invasion. I don't know. Do you regionalize it? Yeah, like send it from the country to Alexandria and to Cairo? Because now in the New York State, in the New York City, actually, I should say, which is about 10, 12 millions, they refer them to Columbia University, most of them, even gynaecologists. Dr. Herzog, before he moved to Cincinnati. Would you centralize it in Egypt to improve on the mortality from percreta? I'm not talking about accreta is nothing. Increta is nothing. But once it goes to the bladder or parametrium, God help you. Sorry it took your time, but I don't know the comment of the group.
Well, shall we redirect that to Professor Nouri, because he's eminent Egyptian professor and he's aware of the local situation, yeah?
Well, we are sure that the placenta, morbid adherence of the placenta
percreta
is the worst of them.
Yeah.
Well, recently there were some discussion whether really placenta is a choriocarcinoma to cause invasion, or it is not really a choriocarcinoma, so it should not cause invasion.
Yeah, it's not.
And many times we can see actually the placenta, dehiscence of the lower uterine segment, even in non-placenta previa. And sometimes we find the accreta is actually dehiscence through this very thin lower segment uterine incision. And some actually saying that why not this increta or precreta is protrusion of the placenta through the disrupted muscles of the lower uterine segment. And so it's appearing in between them. So we are saying this as percreta. And even some say more that maybe in previous surgery, there was injury of the bladder, and that's why there are some scarring of the bladder. So the same as what happened as dehiscence of the lower uterine segment, maybe dehiscence of the bladder. So it's going into the bladder rather than a choriocarcinoma invading this. So I think at the end of the day, if you can control the bleeding by whatever means, either intra-uterine balloon, intra-arterial balloon, aortic or iliac, or maybe the technique that we are doing this, so you can have enough time to displace the bladder downwards.
This case had balloons in the internal iliac, in the uterines before the surgery, and she had every procedure you talked about and you imagined.
Yes.
And she arrested and she died for 35 minutes. And the authors here, they consider that success. 12 hours on the operating table, they don't know, they don't talk about the mental status of this patient.
Yeah.
Well, so, I don't know.
Even the intra-arterial balloons, there are some of the cases, they show that there is severe bleeding with these cases, so it does not prevent it 100%. But the idea, if you can stop the blood flow to the uterus for some time, so you can have the time to do your procedure and allow time to remove the placenta if you can, or maybe leave it in place, or apply the balloon or the tamponade. So there are different ways you can do it, but it's a very difficult, I know it's a very difficult clinical problem that will remain very difficult and need very highly expert people. And that's why there are now teams for placenta accreta, and I'm sure that it should not be done by anyone, or at least under the supervision of this team. Thank you.
Thank you.
Professor Bakri, you are here now, you are the man, and we have to ask
I'm
you
sorry,
about
astaghfirullah. No, I disagree with you. I'm sorry. Yes, please.
You are the man for the Bakri balloon, so I want to find out, how did you come to have the great idea of
Well, it's really, it is.
inventing the Bakri balloon.
Thank you, thank you. It's just like, how do I say? When I speak medicine, I put politics and diplomacy aside. There are balloons in the market today which you should not pay a $1 single for. You have listed, we should be straightforward, honest, courageous, and say things as they are. EB balloon, which you mentioned, and you had a picture of, EBB. The price of this balloon is just as the Bakri balloon. And Bakri balloon, which is used, Bakri SOS, which is 20 years old, has changed now. The one which you have and the one which everybody has is the 20 years old. It has its problems. But the egg balloon, which is $300, $400, and you had its picture, we shouldn't buy it by $1. Dr. Y. Young, we were in a conference and Dr. Bilench was there in Athens, and I asked him, Dr. Y, I asked him, I have never seen an egg balloon except in Salt Lake City, Utah. When I went to the company and I discussed the balloon in Utah at a time when it was withdrawn by the FDA of the United States and the FDA of Canada because of leakage. And yeah, I voiced my opinion about the balloon at that time, but it went back and I don't see a hospital which is using it. So why don't we say it? That's one. Two, the ESM every second matters of Mass General Hospital, which is the condom, is, I consider it a scam. It's useless. It is not worth the $9 which is paid for. I used to write for Up to Date the article of, or the review of uterine balloons. Up to Date fired me, and I'm no longer having this article, terminated my authorship after 15 years because I criticized the condom balloon. The numbers of condom balloon are scams. In Tanzania, in Uganda, in Kenya, it's not right. I know Egypt is in Alexandria, they are using it. I don't know the numbers, but Dr. Ahmad Darwish, when in the paper which came from British Journal of OBGYN, his conclusion was, well, cases which had condom balloon did worse. Oh my God, God help him. So he was honest. You cannot say that today. So in April, I'm completely fired by Up to Date for this criticism, and I'm writing about it. So the condom balloon is useless. A balloon is useless. The rush balloon does not have a drainage. The rush balloon is for postpartum, $100. And it is the rush Foley catheter with the balloon on top of it. So it went down from $2 to $100 because it changed from rush Foley catheter to rush postpartum balloon. This is true. And the very nice doctor in France, in Orleans, France, Dr. Suhail Laweni, published in January of last year about in a commentary saying, don't say tamponade balloon, name the balloon, because you cannot compare the condom balloon to Bakri balloon.
I think, Dr. Bakri, the question was about how did you get the idea?
Well, the idea that there is I mean, there is a privacy issue. The idea is basically, I mean,
Bakri is the first balloon, is the balloon.
Yeah, it was actually, it was exactly in 1989, a patient in a hospital where I was practicing. It was, I'm not practicing obstetrics, but my colleague came and called, well, we have a problem for previous cesarean section, and you have to take the responsibility, and you cannot do hysterectomy, and if the patient die, you know what will happen to you. So I had a Swedish colleague who was the chairman of urology, Dr. Torsten Sandin, and I went to ask him what they have the biggest urology catheter in the department. It was at the King Faisal Specialist Hospital in Riyadh, where you have every system you need devices wise. And we had like 4 or 5 Foley catheter with the capacity of 75 cc. It was placenta accreta lower uterine segment in a 4 previous cesarean section, and ours was the number 5th. Well, in 24 hours, it went fine, and the patient was discharged. But thanks to the CEO, director of the hospital at that time, we went with the biomedical engineering, and we designed in 5-6 years the current Bakri balloon with the way you use it. Yeah. The question of the cost. Now, the company sells it, and it is not patented. I can tell you, I did not patent Bakri balloon. You can manufacture it and call it whatever you want to call it, and it will cost the manufacturing $15 US. Now, if you have one balloon in your hospital, and this came only yesterday, I just put, I mean, I didn't really know that I will come here. So you have the catheter, you take it from the box, and before you insert it, you put a glove on it. Before you put a glove on it, you let your nurse, it takes 30 seconds. After your hand, the skin, you put the glove on your hand. And you work for millions of cases, your skin never touches a tissue in the patient. The same thing, you take this balloon and you put the glove on it. And this is a spoon representing the catheter. I mean the balloon when you insert it before inflation. And this is like the catheter itself. And you can double balloon it and inflate it inside, and it will be like this. This is an orange or grapefruit, which is covered from here, and this will be the catheter, and use it. Inflate it inside. Size 6 glove will take 500 cc's. Size 7 glove will take 700 cc's. And the balloon itself will never touch the endometrial cavity. So sterilize, sleeve, and reuse.
So you can reuse
Your $300 will give you come down to $30.
Yeah, so you can use it, reuse it really.
It's
Okay,
really
I
very
think
useful.
Assam, you had some more questions for.
Yeah, can I just ask
our,
Dr. Alam?
Just one point. Follow the guidelines of the WHO of re-sterilization, and it is the magic of chlorhexidine, which is the Sidex. The nurse can do it after you remove it, and this balloon tissue will never touch the endometrial cavity of the patient, just like our hand.
Thank you very
Thank
much,
you so
Prof.
much.
Bakri. I got a question for Dr. Alam.
Okay.
Sorry, Wafa. Dr. Alam, I got a question for you from Dr. Hind Abdelal here, and she's asking if there is a broad ligament hematoma and the vessel is not visible, what should be the best management for these cases?
Right. Okay. So we cannot really put blind sutures in the broad ligament. As we said, it is a tiger land. So we cannot really just put few compressing suture or pursing sutures. So my advice would be, if there is a hematoma there, do a compression and then ask for help by somebody who can do pelvic side wall dissection properly. So all what you need to do, if you have severe bleeding at any time in obstetrics and gynecology, you cannot see and you are not very familiar with the anatomy of the pelvic side walls, all what you need to do is to get few big swabs, do strong compression, and inform your anesthetist, and then ask for help, and of course get blood ready and everything. Ask for help by somebody who is familiar with this area and familiar with anatomy. But please do not try and start putting blind stitchings in this area, because now if you do that and ask for help, this will make the life very difficult for the person who is going to come and help you.
If there is any role for the intervention radiologist in this situation?
Of course, there is, but this is in case you fail to remedy this surgically. As you know, even in the UK, intervention radiologists are very rare breed, and it might be difficult to get one very quickly. So it might be better to ask for help by a gynecological surgeon who is familiar with the complex anatomy. And if he fails, then intervention radiology can be asked to come as a last resort.
Thank you very much. Okay, Dr. Wafa, over to you.
Yes, thank you. I'm going to ask Dr. Sofia, please. There is many questions about the use of medical treatment alternatively or successively. If we can use the oxytocin, ergometrin, and the carpitocin, can we use all of those together? Can we combine all of them, no interaction? And the other thing for the carpitocin particularly, can we use oxytocin after giving it the carpitocin? And if there is any contraindication for lactation afterwards?
Okay, so I'll start with carbetocin. So carbetocin should be used instead of a bolus of oxytocin and an oxytocin infusion. So you wouldn't use both together. You're using it instead of that. But as I said earlier, and as I've typed in the question and answers, just be careful about using it because it's relatively expensive and there's not any proof that it's of significant benefit. As compared to oxytocin in terms of the prevention of postpartum hemorrhage. That's why we don't use it, for example, in our unit. Now, in terms of use of drugs alongside each other, so we already spoke about the use of oxytocin and tranexamic acid together. We would use that routinely. And all I would say is make sure you've got your protocol to hand and you follow what's normally done in your hospital. We would normally use like a stepwise approach. So, check what's been given for active management of the third stage, check whether tranexamic acid's been given, and then we'll move on from there in terms of ergometrin, carboprost, etc. And then also think about your actions alongside that. So already be thinking about, should I be looking towards uterine tamponade or, B-Lynch suture and so on. So that you shouldn't be using the uterotonics and the antifibrillatory medications, in isolation. You should be thinking about these other actions at the same time.
Okay, and there is another question about the use of recombinant factor 7. The Novo 7, if there is any role for its use in the management of postpartum hemorrhage, and when to start to use it.
So the ERC-RCOG guideline is quite clear that you should only be using recombinant factor 7 in the context of a research trial. So there's no evidence of benefit. I suppose people might use it, in the case of severe bleeding when they tried everything else, but I've got no personal experience. I've never used it, and the college isn't supportive unless it's in the context of research.
Thank you so much. Thank you.
I got a question here from Saima Kohar. She's asking if the patient delivered in the periphery, she delivered at home, and had retained placenta with bleeding, which maneuver should be taken till she reached to the hospital? So she delivered home and bleeding, and we're transferring her to the hospital. What maneuver should we be doing, Dr. Sophia, before we getting her to the hospital?
I think that's difficult. Obviously, the key is to get the patient to a hospital as soon as possible, as near as possible, where she can have definitive management, which would be manual removal. And in the meantime, she needs to kind of be kept warm and hydrated, which of course will be difficult if she's at home. The question may come, is it a planned home birth or is it an expected home birth? Because you could leave, for example, the baby attached. If we have unplanned home births, sometimes that's done in our environment, that you wouldn't clamp and cut the cord, you would leave it attached and just dry and keep the baby with the mum, and that might be better. I mean, it might be worth having an opinion from one of you and your Egyptian colleagues, because you probably see that more often than we do, to be honest.
Is there any role of giving rectal misoprostol before transferring the patient to the hospital? Because in this situation, the midwife don't have the skills of putting cannulas. Do you think they might be able to do the PR misoprostol in the meantime till they get the paramedics and they start the cannulation?
Well, you see, I suppose the uterus can't contract because the placenta is there. So by giving the misoprostol, it might encourage some uterine contraction, but I'm not sure it's going to make a significant difference.
There is
it is unstable until the placenta is removed. So.
If you have the non-pneumatic compression available, then this would help to stabilize the patient till she goes to the hospital. I think using also either sublingual misoprostol, if the patient is is conscious, then this may be very easy, rather than just putting a rectal one. But again, you have to transfer the patient as soon as possible to the hospital. Yeah.
I have a question to Dr. Well. Dr. Fatin is asking who is responsible or decided the decision of blood transfusion. Is the responsibility of the anesthetist or obstetrician or both of them? And there is another question about the definition of tachycardia. Is it just after 100 or when to say that there is a tachycardia?
Okay, so in answer to the first question, the decision for when to transfuse should ideally be a collaborative decision, should be between you and the obstetrician. Of course, what will often happen is the obstetrician is busier than the anaesthetist in trying to stop the bleeding. And so the anaesthetist may well just go ahead and make a decision, but will always be, I think it's important that it is a team approach, and that if a decision is made to do something, then that information is shared so that the opinions can be given as to yay or nay. But I have to say, it's not an area of conflict that I feel that I've ever been involved with. With regards the definition of tachycardia, well, I mean, it's a textbook definition would be of 100. In terms of, it can be difficult sometimes because there may be a tachycardia throughout the whole of labour, which may not be associated with hypovolemia. But I think I'm more emphasising the point that you need to look at any patient with a tachycardia with an assumption that they're bleeding until you can prove that they're not. So there are other causes for tachycardia, but the commonest one is going to be hypovolemia.
Thank you. There is, thank you, Dr. White.
I got a question. Yeah, I got a question here, Prof. That will be for Dr. Alam. Can I leave the placenta for some time in case of placenta accreta and covered by antibiotics and methotrexate?
Yes, but I mean, the college do not recommend methotrexate, and you need to be careful about the infection and the bleeding rate. So you have to monitor the patient very closely. But the college in the Green Top guidelines mentioned that there is no need for methotrexate in this situation.
Thank you. And another question for Dr. Will, please. Is HemoQ is reliable in cases of BPH?
So the HemoQ is a pretty reliable tool. I think most of them are calibrated to be within 0.5 grams per deciliter. So it gives you an accurate result. The only thing to be careful of with a HemoQ is at what stage of the resuscitation you're at. For instance, if someone has lost 2 liters of blood and has not been given any fluid back, they will have an artificially higher hemoglobin than one who has had some volume replacement. And so when you can use the HemoQ as a guide for your resuscitation, but I would recommend that you each time you do a HemoQ, send some blood to the lab and just make sure you're sort of getting it confirmed with a more definitive test.
Thank you very much.
Question to Professor Al-Nouri. Dr. Nahi Chatut is asking about the availability and usage of interventional radiology for postpartum hemorrhage in Egypt. What is the situation? I think so. Professor Nouri, I think he lost the connection for a while, so we can just ask a question to Dr. Halem. There is a question about using the Foley's catheter as a tourniquet while doing cesarean section in cases of placenta previa. Do you have any experience in that, or it could be there is any evidence for this practice?
Well, the use of the tourniquet actually in placenta previa, I've never seen this before, because for the simple reason, I'm not sure how are you going to do that. We use this in fibroid uterus when we can go under the fibroid and we can put the catheter through the broad ligament from both sides to compress the uterine vessels. But I don't know how this will be the case in placenta previa when the lower segment is already ballooned with the placenta, especially in major grade placenta previa, really. So I have not seen any publication. Maybe some of my colleagues can comment on that.
Thank you.
Dr. Muhammad, while you're there, ask you a question. They asking if there is any effect of on fertility for a patient who had a B-Lynch suture inserted.
Well, I mean, I have not seen any evidence of that, and especially the first publication ever in 1997 by Professor Lynch showed a very good pregnancy rate after the application of the suture. So I'm not aware of any studies that showed a reduction in fertility after the B-Lynch suture, if it is properly applied, of course. And I cannot really see the logic behind this.
You're right.
Yes, Prof. Yeah, the effect on fertility, Prof.
You're right. I've had 25 patients who were pregnant uneventfully after B-Lynch suture. None has reported to me of miscarriage or infertility. I find this is astonishing because patients who have promptly contacted me for advice, but none has been.
Okay, thank you, Professor B. Lynch. I think there are a few questions here for Dr. White. There's Dr. Gamal Ahmed who says, thanks, Chris, for the excellent presentation. I think my question is geared here. There is increasing dependence to utilize ROTEM to not give FFPs, platelets, irrespective of blood loss. This is instead of giving 1:1:1 ratio. So if someone bled and is being given 6 units of blood and ongoing bleeding, can we not give FFP by using ROTEM? What is your views about ROTEM and what do you use now in Newcastle? And there's another question about lactate. Is lactate relatively good marker? I think this is from India, from ongoing intra-abdominal bleeding. And there is a question from Peru. Can regional anesthesia be more beneficial in patients with abruptio associated with high blood pressure instead of general anesthesia?
So I might forget those questions as I go on, but I'll start with the one about regional anesthesia. So regional anesthesia is certainly safe in the presence of abruption. There are some issues. It's always more complicated than just a simple answer. You need to, in cases of abruption, there's often time critical for delivery. Even in the best hands, trying to get somebody ready for surgery with a spinal is going to take longer than a general anesthetic. So you have to consider the delivery of the baby safely as well. But regional anesthesia is safe with abruption. In terms of, does it affect the bleeding compared to general anesthesia? I don't think so. Second question is about lactate. Lactate is a very good marker for end organ perfusion. If your resuscitation is keeping up, your organs, your perfusion is resulting in lactate not accumulating, and so if you're seeing accumulating lactate, it can be a good guide to that somebody is behind in their resuscitation. You'll have to remind me of that first question.
What are your views about ROTEM?
Yeah, so we use a ROTEM in Newcastle. I have to say we we owe a lot to Cardiff. So Cardiff
What
in Wales.
ROTEM? For those who don't know, what is ROTEM? What is ROTEM?
The ROTEM basically it's a device that looks at a fibrin clot formation. It is equivalent to a thromboelastograph. It's a point of care test, meaning you can use it at the more or less at the bedside. It gives you when you put a blood sample into it, it analyzes the speed that a clot forms and the strength of the clot. And so it can give you a guide to both the intrinsic and the extrinsic clotting pathway. The advantages of it are obviously that it gives you immediate results. It takes only, once you put the blood in it, it only takes you 5 to 10 minutes to get the answer that you need. The downside is that it does require a certain amount of training to interpret the results, and it is still not considered to give as reliable results as a proper lab coagulation test. But we certainly use it in Newcastle. As I was just about to say, we owe a lot to Cardiff. Cardiff has done a great deal of work in postpartum hemorrhage, and they are the ones who published that paper I was talking about in the Blood Journal, and they have managed to massively reduce their FFP use to the extent that when we were in communication with them about a year ago, they'd only used 3 units of FFP in a 6-month period, which is astonishing when you consider they're a large unit like we are. So yes, they are using the ROTEM to guide them. They are using a lot less FFP, a lot less cryoprecipitate, a lot fewer pools of platelets.
Thank you. Dr. Hamami.
I think we're coming to an end now, and thank you very much for keeping everybody very late. And in UK, it's still early, but in the Middle East here, it's coming to midnight. So great webinar, and very, very grateful to all our speakers. And now we're back to Professor Salam to conclude the conference. Thank you.
Well, thank you very much, Dr. Hamami and Dr. Wafa, for your moderation, and thank you very much for all the speakers. Professor Christopher Billinch, it was a great pleasure to have you with us, and we really like to thank you very much for taking up your time. And we are also honored by having Professor Yunus Bakri, who we hope to see everybody here. Of course, Dr. Sophia Webster is a good friend of ours, and she's here often, and also Dr. Mohammed Alam. And I hope we will have the pleasure of welcoming Dr. White in Egypt when this Corona madness comes to an end. And with this, I want to pay tribute to Professor Amr Nouri, because as I said at the beginning, he is the person who started all these activities 10 years ago when we all started, and he is the person who brought Professor Christopher Billinch to Alexandria, to the Suzanne Mubarak Regional Center for Women's Health and Development, as it is called then. And I think Dr. Bakri also paid that a visit over there, but not on the same occasion. And I hope everybody comes to Alexandria. It's much better than Cairo, I promise you. And with this, I also thank all our attendees. My understanding is that we came over 2,000 attendees, and this is why Dr. Mai, the organizer of the workshop, has put it live on Facebook, actually, to go beyond the 2,000 mark. And finally, I would like to thank Merck Pharmaceuticals for supporting us in in many of our activities. And thank you very much. And as we say in French, à la prochaine. I don't know if anybody speaks French. I know Hamad Alam does, but I don't know about anybody else. And thank you very much, and see you again soon, hopefully. And
thank you very much.
Thank you.
Thank you very much, Professor Billinch. It was a great pleasure.
Thank you.
Thank
It's
you.
most enjoyable.
honor and pleasure.
Dr. Sophia will fly her own plane back to Africa now.
Yeah, why not? Tomorrow.
Yes, of course. I forgot to say that Dr. Sophia has flown from the UK to the southern tip of Africa with her. She flies on her own. She flies the plane.
Landed in more than 20 countries.
Yeah, a little bit more than that. Yeah.
A lecture of its own. Yes.
Yeah.
Thank you for remembering.
Thank you.
All right. And,
Yeah.